So good noon, everyone. Welcome to all the delegates who have logged in, as well as the esteemed and formidable lineup of faculty members that we have for this beautiful Sunday afternoon. So we are on to the third and final day of second edition of BIC. So this is the first session. The topic of this session is complex case, complex decision, peripheral artery disease. So this session will be moderated by Dr. Tarun Madan. Sir doesn't need any introduction, but nevertheless, I'll give a brief introduction about Sir. So Sir is an associate professor of cardiology in UN Mehta Heart Institute, Ahmedabad, as well as the director of endovascular intervention, Star Hospital, Ahmedabad. So Sir, over to you for this session, sir.
Thank you, Atul. Without delay, I would like to use our honorable chairpersons. Dr. Rajesh Vijayvergia, sir. He is a professor in cardiology at the Premier Institute in North India, PGI Chandigarh. Dr. Sanjay Mehrotra, sir. He is a senior international cardiologist in Narayana Hrudayalaya, Bangalore. And Dr. Cherian Mathew, sir. He is an intervention radiologist in Kovai Institute, Coimbatore. And our esteemed panelist, Dr. Bedi, sir. He is a senior most vascular surgeon in Sir Gangaram Hospital, New Delhi. Dr. Gireesh Warawdekar, sir. He is a senior intervention radiologist in Lilavati Hospital, Mumbai. Dr. PC Gupta, sir. He is a vascular surgeon in KR Hospital, Hyderabad. Dr. Siba Shankar Dalai. He is a senior intervention radiologist in Medicover Hospital, Vizag. Professor Dr. N.N. Khanna, sir. He is a senior most interventional cardiologist, Apollo, Delhi. And Dr. Vijay Kumar, sir. Additional Director, Fortis Escorts Institute, is a senior interventional cardiologist. So welcome you all on the dais, and with the permission of chairperson, we would like to start the session now. Rajesh sir and Sanjay sir. Hello.
Yeah, I'm ready, Dr. Madan.
Okay.
Rajesh has to present first, I suppose.
Rajesh, you have to present the first case. Sir, BTK calcium is a real challenge. Over to you, sir.
He's muted.
Rajesh, sir.
Yeah, it's okay now.
You can share your screen now. Sir, your video is not visible. Rajesh, sir. If there is a technical glitch, Rajesh, sir.
He's there.
Yeah, your video is visible now, sir.
Sir, were you addressing? I think there are a lot of sirs out here.
Sir, if there is a technical glitch, we can go to second presentation by Dr. Sanjay Mehrotra. We can re-invite Dr. Rajesh later on, or he has started, I think.
No, this is mine. This is mine.
This is Sanjay. This is Sanjay.
Sir, heart failure treated with IVL and stenting of aorta. I think it is an interesting case. Over to you, sir.
Thank you very much, Dr. Madan. This is an interesting case. Can you see my slides, please?
Yeah, I can see them,
Yes, sir.
Sanjay.
Visible.
Yeah. Dr. Cherian, how are you? Long time.
Hey, yeah, pretty
Right.
good.
So, this is
Hey.
an interesting lady who actually was presented, who came back from another city while COVID time. So she was very desperate. She was in heart failure, came in a wheelchair with bilateral significant pedal edema, could not lie down. She was 56 years of age, and she had dyspnea since last almost 2 to 3 years, PND and orthopnea for the last 3 weeks. And she was in functional class 4 of congestive cardiac failure. Her bilateral femoral artery and bilateral peripheral vessels, the dorsal pedis and posterior tibial pulses were absent. She had raised JVP and of course pedal edema, hypertensive. When she came to my room, her blood pressure was 200 by 110 in the upper limb, and the lower limbs were not palpable. So obviously some kind of aortic obstruction, which was very evident here. Although this patient had a CT, but I did not have access to the CT. She was diagnosed elsewhere to have a descending thoracic obstruction with cardiomyopathy, ejection fraction 25%, function class 4, but normal sinus rhythm, very high ESR, and the CRP was also borderline high, no COVID. And renal dysfunction, creatinine 1.9, and the GFR was low. Her abdominal ultrasound showed bilateral renal parenchymal disease with maintained corticomedullary differentiation. Renal Doppler shows diffused reduction in peak systolic velocity involving bilateral main renal arteries as well as the intrarenal branches. But there was no stenosis noted. And there was dampened flow in the abdominal aorta. The kidney size was reasonably okay. This is the CT. I'm going to move it fast. So I've actually deliberately shown you the plain CT because this, you can see the calcium ring there. I'm moving quickly, coming down somewhere just behind the heart. And this is about T8, T9, T10 level, completely occluded aorta by calcium. So obviously it's a case of probably aortoarthritis. And when you come down further, you see that the aorta is okay. The size of aorta, which was the inner lumen of the aorta, measures around 12 to 14 below and about 16 to 18 above. The overall aortic size was measuring around 22. And you see complete calcification. Now, when we see these kinds of cases before we had the availability of the IVL, we used to get very worried that this is not going to open. And being in heart failure and a total obstruction, of course, the CT confirmed there was an obstruction of the aorta. And I will show you this picture now. So you see around T10, the aorta is completely occluded. But on the CT, and that is very important to see in such patients, there was a lumen which was visible. And you will see that the wire probably will go up with some effort. And I'm trying to sort of pass the wire. This is a Terumo wire. This is not a PTCA wire. I thought, but this is a 025 Terumo. You see the Terumo goes up and then the catheter went up. Now you see almost like a bunch of calcium here across this T10 vertebra. And this was very, very dense calcification. There was an aneurysm which is located somewhere around T2, T3 in the descending thoracic aorta, but that aneurysm size is only 33 or 35 millimeter. So although I had kept a covered stent graft, I had no intention to treat this area because this was not obstructed. This was the pressure difference between the proximal to the aorta and distal to the aorta, which is pretty significant. The pulses were not palpable, but you can puncture them because they were all collateralized from the various kinds of connections between the superior and the inferior aorta. Now, I could only use a 4 millimeter balloon to pass this up, get some access. You dilated this using this 6 millimeter balloon, following which there's now a pigtail and you can see the IVL catheter. So you're inflating the IVL catheter, and as per recommendation, you go to 4 atmosphere and then you deliver so with the peripheral balloon, you get 30 cycles each, and there are a lot of cycles, I think 280 total. So I went first to open, and you can see the balloon expanding while you're giving the IVL. This is an expanded balloon, which is the IVL balloon. And the next stage is, of course, to put another balloon to transmit the impulses, the sonic waves, using what you call as a kissing technique, where one of them is an IVL balloon and one of them is a plain balloon. Now I used, we had the 7 millimeter IVL balloon, and I used another 7 millimeter balloon to expand the aorta. And after expansion, you will see now there is flow. And then you advance, this is an Andra stent, which is mounted, crimped onto the balloon. This balloon is 16 millimeter. I, of course, measured the aorta proximally, which was coming around 18. Distally, it was about 14. So we decided we'll go around 16 millimeter and will not do a very high pressure inflammation, just to sort of approximate, create a lumen. And you will see stent in position. This is the expansion of the stent, which gives you, and then of course, you see proximally the aorta is larger. So I'm trying to do a slightly, eccentric expansion of the balloon so that I get a better opening of the proximal stent. Although I will not bother too much about, you're trying to do a very good job here. And following this, the patient's pressure equalized and she became completely, within the next 2 hours, actually, as soon as we opened, the pressure came down in the upper limbs and we had to stop her all antihypertensive agents. I think there was a renovascular component in it. There was a significant improvement in her general condition. She became completely asymptomatic, never had the edema again. She stayed 2 days and showed me before going. After about 3 days, the blood pressure in the upper limb became 140/90, which of course will take some time to go, but that was my case. So we used, in a case of aortoarthritis with significant amount of ring-like calcium across the aorta at the location of T10 to get this result. And the patient, this was very successful. So I think we have an option to treat these patients now with IVL. So I'll stop sharing and I will invite questions.
Sir, very nice presentation. Heart failure with a significant amount of outflow obstruction, which creates a good afterload on the left ventricle, and the left ventricle dilates and ultimately develops cardiomyopathy. Very nicely managed with IVL. I think a similar case was done in Ahmedabad by Dr. Milan Chag, where he used 2 IVL balloons parallel kissing. So because they don't have a large single balloon, they use 2 parallel IVL balloons to dilate the session. I think we invite comments from panelists, Dr. Bedi sir, Dr. Gireesh sir, and Dr. Cherian sir.
Sorry,
yeah.
Sorry, Dr. Bedi, please carry on.
Yeah, no problem, Dr. Mathew. Please go ahead.
Honestly speaking, that calcium looked much worse than I'd seen, and it's seriously amazing that you could get such a great result. No, I just commented on that, but I was just going to ask: is it necessary to use 2 IVL balloons? Because this stuff doesn't come cheap, and you got a fantastic result with a single IVL and a second 7 mm peripheral balloon. I think if you can get that, do you really need a second IVL balloon?
No, I don't think so, Dr. Cherian. 1 is enough because it's very expensive. And, the total cost, especially if I had to put a stent graft, which I've asked them to put on hold, although there was no need to use a stent graft, total cost was pretty high for this patient because Andra stent is also pretty expensive. So what I did, that I rotated the balloon. And so initially I put on one side and just rotated a bit on the other side. Yeah. Using a single balloon, you can actually crack the calcium. What it does, it makes your artery very, supple.
Supple, yeah.
Suppleness, it is what is needed. You crack the calcium, you don't need too much. And then your stent does the job. And
absolutely.
I think it was so interesting that we have seen in the coronary also, although I've had perforation with it in the coronary tree, and I presented it last time, that you have to be careful because sometimes the spike-like calcium and you need to be very careful that you don't overdo it. And that is why I did not want to expand that occluded area. I might call this patient after 6 months and see if there is some under expansion. You can go again, expand it, because there is a risk that you can perforate the aorta. And perforation in a calcified aorta may not be able to seal so easily with a covered stent. So that is why I just used 1 IVL balloon and it worked very well.
I'm sorry, Dr. Bedi, I interrupted you.
No, absolutely fine. I think you brought out the highlights exactly what I was also going to ask, but I think it's wonderfully managed. And that's one thing which was there, that probably, the way the calcium remodulates out there is something which, it's very difficult to comprehend actually when you look at it, what happens, because it looks like absolutely a normal kind of a balloon. And then suddenly probably it works wonders inside the artery. And that's something which is amazing, and that is why it has got a lot of imagination and a lot of use also today for managing aortic aneurysms, where you have these dense calcifications out there, and you need to manage. So I think compliments to Dr. Sanjay Mehrotra, very well managed. I think that is really very well done. I think that is where the primary indications of these balloons are probably where And even probably in certain situations where you don't want to put in any hardware. Let's say you have a calcium in a common femoral artery, and that is one place which we consider as a no stent zone, and you have a patient who's got a low ejection fraction, and you just want to get out, to bail out a limb and all, probably that is where the indications are very, very good that way. Thank you.
Sir, was it a covered stent?
No, it's just a
no,
bare
it's
stent.
not. Bare stent.
I don't think the covered stent again increases.
No, but I think, Sanjay, I would never put a covered stent there.
Yeah, true.
Because, it's a zone of the spinal artery. And it's a good idea, just to always keep that in mind. We start with something simple, end up with a paraplegia, not worth it, Yeah. So I think that was fantastic. I mean, I think it was brilliant. So the choice of hardware and...
Thank you, sir.
I have a little contrarian viewpoint, Dr. Mathew, if I may say so. Short stents and all, even in the thoracic aorta, the chances of developing a paraplegia and all are very low. The only thing is because all these patients generally have very good spinal arteries because of the collateral supply, which is already there, because there was an occlusion out there. And that's why, you have already a lot of collaterals which have already developed. The second thing is, one is always a little worried, and as Dr. Sanjay also felt, that in case you have some kind of a rupture, then it becomes a challenge as to which is the device that you can use in these kind of situations, because a AAA device is too soft a device which can be used out here. And the only thing that probably that you can use is a fluency out here, which is the maximum size of 13.5 millimeters. 13.5.
Yeah. So you won't be able to use it.
Or you can use the Andra covered stent also. That probably is a better possibility. That is in a stenotic region that might.
Or a CP. But then there was no need to actually even think about a covered stent.
No, what I meant was really that. I said if there's no need, why put it? But, I would have kept a covered stent in the shelf without any doubt.
Yeah, true.
Because if it starts bleeding, then of course it's a different story.
So we go to the next presentation.
I agree,
Dr. Rajesh is ready with his presentation. Below the knee calcium is a real challenge. Drug-eluted balloon versus IVL, choice of treatment. Dr. Rajesh, sir, please share.
Thank you. Let me share my presentation. Are you able to see my slide? And
we can see.
Am I audible?
Yeah, you just got to come on your presentation mode. That's all.
Is it okay now?
Yeah, perfect.
Okay, nice. So Tarun, thanks for the invitation, and sorry to join you all late because of some technical problem
on
my laptop. So let me go ahead. I'm going to cover the aspects regarding the management of infrapopliteal calcified peripheral arterial disease. No conflict of interest. As you all know about BTK disease is more likely to have a CLI than the claudication, and these arteries, the three arteries below the popliteal trifurcation or bifurcation, are smaller in caliber, most of the time diffusely disease, frequently calcified, especially in those with diabetic and renal failure patients. Restenosis and repeat intervention are more common for these arteries because of smaller caliber, diffuse disease, poor distal or proximal runoff. So the goal of BTK intervention is post-intervention arterial residual stenosis less than 30%. And the greater the number of the patent vessels, the higher the likelihood of the functional limb salvage. Patency of one or more tibial arteries generally preferred over the patency of the peroneal artery. And if you see the data for, say, 1 year limb salvage following the PTA for 0, 1, and 1, 2, and 3 patent infrapopliteal artery, the salvage rate is markedly different for each and every category, extending from, say, 56% to 83% at 1 year of follow-up. Certain definition regarding BTK intervention. Technically, of course, the residual stenosis should be less than 30%, but most of the time we don't have a cold laboratory to have an idea about how much the residual stenosis is there. And then the follow-up angiogram should show a less than 50% recurrent stenosis following the intervention. Hemodynamically, the ankle brachial index should be, say, 1 or more than 1 following the intervention, and then there should not be more than 0.15 ankle brachial index deterioration at the follow-up following the intervention. Regarding the pulse volume, the distal to reconstruction pulse volume should be more than 5 millimeter above the preoperative tracing, especially in those with the non-compressible vessels. And clinically, the immediate and sustained improvement by at least one clinical category should be there, and those with the Rutherford type 5 and 6 critical limb ischemia, it should move to at least 2 category above, and the claudication should subside. As you all know about the calcification scoring for the infrapopliteal lesion, it is grade 0 for no calcification, grade 1 for unilateral calcification less than 5, grade 2 for unilateral calcification more than 5, grade 3 is bilateral calcification less than 5, and grade 4 is the one, which is the severe one, having a bilateral calcification with more than 5 centimeters in the length. Regarding the principle of percutaneous intervention, there can be different approach by the individual operator, as there is no clear consensus about how to manage the BTK disease. There is a lack of large randomized prospective trial, absence of independent cold laboratory assessment of device-related acute and late result, and also the event. PTA traditionally been used for BTK lesion, especially those with a focal lesion, and the early elastic recoil, frequent dissection, and poor primary and secondary patency rate for the long lesion, with 40 to 50% of the cases requiring bailout stenting. Balloon angioplasty has the limited role, especially in those with severely calcified disease, despite having an acute good result following the intervention. In densely calcified vessel, adequate debulking is also required to achieve the optimal angiographic result and also the long-term patency. Let me go ahead for the various interventions being done for BTK. It's include drug-eluting balloon, stent, atherectomy, IVL, and role of imaging. First of all, drug-eluting balloon. As you all know, there is a contradictory result about the use of drug-eluting balloon for infrapopliteal lesions. Debate BTK is the study where it is found that the drug-eluting balloon is found to be superior compared to plain balloon angioplasty in terms of 12-month restenosis, occlusion rate, and also the target lesion revascularization. However, the impact deep randomized trial didn't find a significant difference between the two arms, that's a drug-eluting balloon from the Medtronic versus plain balloon angioplasty, whether it's a 12-month late luminal loss or 12-month clinically driven target lesion revascularization. So both the arms had more or less similar result at 1 year follow-up. Another study, DEB Impact Global investigated 3-year clinical follow-up of 1,500 patients of the complex infrainguinal lesion. The freedom from CD TLR was 76%. The all-cause mortality was 11.6%, and the major target limb amputation was 1%. So somewhat encouraging result of the drug-eluting balloon. And in this particular study, it was found that those patients who have an increased lesion length, reference vessel diameter less than 4.5 millimeter, in-stent restenosis, bilateral disease, CLTI, and hyperlipidemia are the ones who are going to have a worse prognosis. Impact D 5-year outcome, a randomization was done between the drug-eluting balloon versus plain balloon angioplasty, and there is no significant difference between the two at 5 years of follow-up. There is no, and then one important thing which is been found out of this study was that there is no increase in all-cause mortality for drug-coated balloon angioplasty compared to PTA alone. So this was a concern regarding a high mortality in the patient in which the paclitation-eluting drug-eluting balloon was used for the peripheral arterial disease, but then this study didn't show any significant increase in the mortality. The rate of major amputation, freedom from CD, TLR, everything was equivalent to PTA as such. The another balloon from the Biotronic BioLex P3 global registry, in which 877 patients and around 1,000 lesions were assessed. 17% was a BTK lesion. At 24 months of follow-up, the freedom from AIDS was 83%, and the all-cause mortality was 12%. This study has shown that this another drug-eluting balloon, is also found to be efficacious in treating the BTK lesion. So overall, with the drug-eluting balloon, the efficacy is somewhat doubtful for the infrapopliteal lesion, and the short-term balloon-based paclitaxel release, which has been done by this balloon, is not found to be so effective for the long-term patency of BTK lesions. Regarding the stent, we do have now 4 trials and total 514 patients of BTK, in which the drug-eluting stent were compared with the balloon angioplasty or bare metal stent, and it is found at the 1 year, the patency rate was quite better with the drug-eluting stent compared to bare metal stent or balloon angioplasty alone. Recently, there is the data about the Absor stent being used for the BTK lesions, and a pooled analysis of 121 patients, 161 lesions, has found that the freedom from the restenosis was 92 and 87% at 12 and 24 months of follow-up. Freedom from CDTLR was 97% at 12 and 24 months of follow-up. So this result is also found to be encouraging for the use of bioabsorbable stent across the BTK. So overall, regarding the drug-eluting stent, it's effective, of course, for the focal lesion, those who had a low flow-limiting dissection but severely calcified disease, and those with the long disease is the one which are not suitable for the drug-eluting stent. Regarding the atherectomy, it's to help to minimize the neointimal hyperplasia by debulking the atherosclerotic and calcified plaque, and therefore the short and long-term patency of intervened vessel is found to be superior. It again helps in prevention of the local dissection and also the plaque shift, which is also a concern when you are dealing with the bifurcation or trifurcation lesion across the infrapopliteal territory. A combination of atherectomy with the drug-eluting balloon should be considered, at least for those who have a diffuse calcified lesion. These are the 4 different atherectomy systems, which is FDA approved. One is the plaque excision, that's a directional atherectomy. We do a silver hawk, turbo hawk device from the Medtronic for this particular entity. Rotational atherectomy aspiration for the jet stream and routine coronary rotabur is available. That jet stream device do have an additional aspiration along with rotablation, lesser atherectomy, and then orbital atherectomy, which has a diamond back device available with us. For those who have a highly calcified diffuse disease, orbital atherectomy and directional atherectomy, which is found to be more effective, but then it's availability and individual operator experience, which is helpful to have good success by using these various devices. Coming to individual devices, direction atherectomy. So definite LE study, 800 patients were used, and the rate of distal embolization, dissection, and perforation were 3.8, 2.3, and 5.3% respectively. At the 12 month of follow-up, the primary patency was 78%. The rate of freedom from major unplanned amputation was 95%. So this has shown an encouraging result with the direction atherectomy. Another study is regarding, say, atherectomy with additional uses of various technology in 240 patients. So it's an IVUS guided directional atherectomy using the TurboHawk device with a drug-eluting balloon, that's an Admiral from the Medtronic, and using distal protection device, that's a Spider FX from the Abbott Vascular, to treat the calcified femoropopliteal lesion, and found to have an encouraging result at the 1 year of follow-up, with 90% and 100% primary and secondary patency of the intervened vessel. Regarding laser atherectomy, B laser been used in one of the study involving 97 patients, 107 lesions, and found to have an improvement in the luminal diameter following the laser therapy. At 30-day outcome, there is no target lesion, revascularization, and the patency with the duplex ultrasound was around 97%. So found to be effective. Regarding orbital atherectomy with balloon angioplasty, compared with the balloon angioplasty alone in the CLI calcium 360 randomized trial, which include the 50 patient and 1:1 randomization was done using the Diamondback 360 orbital atherectomy system. The procedural success was good. It was around 93%, and the bailout stenting was relatively less in atherectomy arm. That's a 6.9 compared to say 14.3% with the balloon angioplasty arm. There was no significant difference between the result at 1 year of follow-up using say atherectomy with PTA alone. Another is the rotational atherectomy, in which the coronary were used say 2.25 millimeter in 65 patients, been randomized to rota group and non-rota group, and then it was found that there is a non-significant improving trend towards higher amputation-free survival compared to the control arm. And this is the JAT stream rotablation system in 172 patients and 210, which are 10 lesions. The clinically driven target lesion revascularization rate at 6 and 12 months were 15% and 26% in the particular arm. So these various devices are found to be effective, of course, to have a good angiographic outcome, but clinically they are not found to be equivalent or superior, at least not superior to the plain angioplasty for the BTK lesion. So there is no comparison between the efficacy and safety of various four FDA-approved atherectomy devices. Though it do reduces the burden of soft atherosclerotic calcified plaque across the vessel, change the vessel compliance, reduce vessel wall trauma, which lead to decrease in the need for bailout stenting. There is also a concern about significant higher capital equipment related costs, particularly when the use in conjunction with various devices, like in one of the studies, it's a distal protection device, imaging, and also the lead to increase in the procedure duration and exposure to radiation. So what is ideal? Atherectomy with drug-eluting balloons should be considered for the infrapopliteal lesion. But however, there is additional studies are required to establish an optimal cost-effective therapy, which may include a combination of atherectomy and other emerging technology for selected BTK patients. IVL therapy, we do have a peripheral IVL balloon, which is of variable length, longer than the coronary balloon with the 6 emitters. And Disrupt BTK is the trial in which BTK lesion in 20 patients were tried with the IVL balloon, and at 30 days, there was no major adverse outcome. If you see the pooled analysis of IVL therapy for the peripheral arterial disease among 336 patients, there is a significant improvement in the luminal gain following the IVL therapy, and then complications like flow limiting dissection, vessel perforation, distal embolization, thrombus formation, abrupt closure, and no flow occurred in very less number of patients. That's a 1.2% of the patients. So it is found to be effective and also the safe to be tried for the BTK lesion. There is certain amount of role of imaging. We do have the OCT guided peripheral atherectomy system, that is Pantheris system, which consists of a catheter with a rotational stainless steel cutter blade with the internal OCT fiber and an apposition balloon to have an adequate atherectomy across the vessel wall. So this is one of the trials being used by, which has used the Pantheris OCT guided atherectomy system. 158 subject, 198 femoral-popliteal lesion, and then it is found that the OCT guided atherectomy is safe and effective. Additionally, the precise affordable OCT guidance lead to better removal of plaque during atherectomy while sparing the adventitia. These are a few of the pictures of the infrapopliteal images with the OCT, which could very well define about the calcified plaque and effectiveness of various atherectomy device across. Regarding the imaging IVUS guided BTK intervention, it is found that the mean balloon size is on higher side when you are going to use the IVUS compared to angiography alone, and the wound healing rate is also significantly better in case the IVUS guided optimal angioplasty treatment is given to this patient compared to angiography alone. However, the pooled analysis of role of IVUS therapy in the peripheral vascular intervention found that there is no significant difference between the two arms, and there is a similar primary patency and re-intervention rate, whether you are going to IVUS or angiography alone. So at last, the take-home message, calcified BTK lesions are technically challenging for percutaneous intervention. Ideally speaking, the BTK intervention should include an adequate plaque modification, which can be done by, say, atherectomy or IVL therapy, followed by balloon dilatation with the controversial result coming out of the drug-eluting balloon. The choice can be individualized whether it's a non-drug-eluting or drug-eluting balloon for this subset of lesion. There is a need to have a prevention of distal embolization and gangrene formation distal to the intervened vessel, and for which there is a need to have aspiration and also the distal protection devices. There is a need to have a prolonged drug elution, as we have found that the drug-eluting balloon is not so effective, and the long-term patency is not found to be better, for which either it's drug-eluting stent is better, but then the limitation of the drug-eluting stent, we don't have such a long stent one, and then with the longer the length of the drug-eluting stent, one is likely to have an in-stent restenosis, and the long-term patency is found to be on the lower side. And then this is the upcoming imaging modality, like we are using for the coronary. And this vessel, infrapopliteal vessel, are also the smaller size. And then there is a definite role of imaging, and more trial is required to have an idea about, to have an impact of imaging and optimization of, say, angiographic result following the BTK intervention. Thanks for kind attention.
Thank you, sir. You have exhaustively covered BTK calcium. Comments from the panelists and chairperson, sir.
Very little. We are left speechless, Ashley, because you have done an extensive review of everything. So,
thank you.
So, but Dr. Bedi, I mean, for everyone here, yeah. Having said this, there are some of us who have been in this business now for more than 30 years. And every few years, we get a new device coming to the market, What's your gut feeling? I mean, I think, honestly, if you ask me, I think this is a device that might stay, Yeah. So since he has covered, what is your gut feeling?
Yeah, it looks quite promising. The only challenge which is there in this one is that, most of the patients we get with BTK, you will probably find less than 5% will have just a stenotic discrete kind of lesion. So your major challenge in these patients is a long lesion, multiple stenotic lesions, and you run out of time with this catheter. Unfortunately, it's only limited to those many number of pulses which are there. So that is the major challenge. What I feel that probably they need to come out with something. And I think
15, 20 centimeters
highlight out here, which we need to highlight for all these BTK interventions, is that only intervene if there is tissue loss, not otherwise. Do not touch them with a barge pole unless and until there is tissue loss. And I somehow, my feeling is that whenever we look at the patency and all, in other situations, we look at the long-term patency. In BTK lesions, our patency is only limited to wound healing and nothing else. If the patient has got wound healing, whether it lasts for 1 month, 1 year, 10 years, and all that sort of thing, it doesn't really matter. But what really matters is to get the wound to heal. So I think primary endpoints have to be very, very clear in these patients. So I think brought up by very well.
That's it. Yeah. I think the only aim is to salvage that limb. That's it.
So
I agree totally. The lesions are 20 centimeters, and finally, at the end of the day, some of them have hardly any flow below the ankle. So we are looking actually forward for Tarun, I mean, the company to come up with 20 centimeter long balloons, which would definitely make it a little more practical for us rather than taking this little balloon up, and it's over, Right. Hi, Gireesh.
Hi.
Hi. Can I just come in? One comment on what's been discussed so far. I think we are going a little bit astray when we say that our aim is only to heal the lesion and then forget about it. It's okay for a person who's got a bad heart, who doesn't have longevity. But I think even for patients with infrapopliteal disease, longevity or the patency of graft or the intervention would matter if the patient has a long way to go, especially who's a diabetic, especially who's got a very sensate foot. I mean, these are patients who are going to come with recurrent ulcers. And how long are you going to keep on re-intervening? So if you have a procedure which gives you a longer patency, I think it's definitely worth looking at it.
No, but Dr. Gupta, in the end of the day, we have seen, here's a guy who comes with a non-healing ulcer or even a toe gangrene. We open the vessel up, and once the wound has healed, he seems, with good foot care, he seems to carry on for 2-3 years. The vessel is blocked. So one thing we have realized, the oxygen demand is very different for a wound that is open versus a wound that is healed. And I totally agree with Dr. Bedi. We are not focusing so much on patency because it doesn't seem to be the big issue. The issue is once we get the foot healed, he's much more responsible. He takes much better care of his foot. He goes for easily, we find 3 years, 3.5 years.
No, I don't disagree with the oxygen requirement and the foot remaining good if good foot care is taken care of. But quite often we do see in real life, it doesn't happen. So what we are talking about is maybe a smaller percentage of patients, but there is a fairly large percentage of patients who will come back with recurrent ulcers, with recurrent wounds. And I think we should not be led astray by this statement that patency is not important. I think it is important.
I would just add a proviso, Prem, out here, just to be on a little bit of an opposite viewpoint. One is that disease progression is a part of the nature. So these patients, it's just that, any lesion that you are addressing today, tomorrow it is again coming back or somewhere else it's going to come up. So there's nothing which is going to give you lifelong, guarantee that, okay, this is going to work forever. So any intervention that you do, you try your level best to keep it long-term as possible with medication, with intervention, whatever you do. But there is no way that you can guarantee that, it's going to last forever. So that's what.
When we talk about guarantees, we are not talking like this. I mean, we never talk about guarantees. But yes,
Gupta, he's not telling that way. What he's trying to aim is, it is holistic care. Finally, it's like everybody working together. I think diabetic foot is really interdisciplinary.
No, Mathew, I do not disagree with you in that.
Sorry to interrupt.
I agree that once lesions heal, just let me complete this bit, but I think it's an important message, and we need to make sure that the right message goes through and not the wrong one. Patency does matter. It is okay, holistic care, the wound heals once, but you have patients who will come back with recurrent ulcers. And to answer your question, Varinder, about long-term patency and disease progression, all of us as surgeons, we have patients who come back after 5 years or 10 years with patent distal bypasses. But you do not have any patients who come back with distal patent or patent tibial angioplasties. So
100%.
So, I mean, we should not make drastic statements which convey the wrong thing. That's all.
The aim is basically that healing the patency should be as long as possible. But unfortunately, there are too many factors which are there which tend to interfere in that one.
So as long as we make a qualified statement, I think I'm okay with it. But a blanket statement, I'm not okay with it.
No. We agree with you totally.
Tarun,
it's fantastic.
Tarun, I just want to make a comment about as rightly said, one thing is primary endpoint of say wound healing, which is of course within 6 months we do a comparable result at 1 year follow-up. But then, as Dr. Gupta has rightly pointed out, we have to look for the long-term patency, and for which amputation-free survival at say 1 year, beyond 1 year, say 5 year. One of the studies of 5 year equal between the two, which is a concern. Wound healing is going to take 6 months, but then long-term patency is helpful to have now amputation-free survival. So that's one thing. And of course, BTK lesion require a comprehensive approach, which includes the wound care, long-term patency, and of course the intervention. there is a definite role of surgery, which is class 1A indication for this. And till now, the evidence for BTK intervention, percutaneous BTK intervention class 2A or 2B as per the European guideline, with the evidence is C. So you have to keep in the mind that there are certain patients where the surgery is going to be the best one instead of going for, say, percutaneous intervention.
True, sir. True. I think, sir, we are running short of time. We can move to the next presentation. Dr. Professor N.N. Khanna, sir, has joined. Sir, over to you. Complex case, complex decision, PAD, your presentation, sir. Please start, sir.
Can you hear me?
Yes, sir. Loud and clear and visible slides, sir.
Thank you very much for inviting me. So I'm going to make a presentation which is very short and maybe require some discussion in the 12-minute which I've got. So this is a case it's a venous case of a massive deep vein thrombosis in a young ambulatory male. So, in contrast to our classical, teaching and understanding that it happens in more commonly, or it happens commonly in, in non-ambulatory bedridden patients who have chronic disease in old people. That is true, but many a times now we have seen very young people who are very ambulatory and not dehydrated or did not have an injury or a provoked DVT. Come with massive pulmonary embolism, and on the workup we find that these patients do have some hypercoagulable state, and we need to treat them and save their lives and also protect their limbs for further quality of life and longevity of the life. So venous interventions is becoming more and more popular in our country, and it's being picked up by many people and cardiologists, and vascular surgeons. Let me take you through one of the cases. He's a young male who presented to us on 29th of January 2018. And this patient had a massive thrombus in the right common femoral vein, a common iliac vein, external iliac vein, and also IVC filter which was occluded. Interestingly, this patient presented with pulmonary embolism and a DVT in another hospital where he was lysed, and an IVC filter was put, and after a few days, the patient was discharged, and he came to us after a few days with this presentation. So I'm going to take you through, this is the angiogram which is done through the right side, right common femoral vein. You can see the filter, and you can see there is absolutely no flow beyond the iliac, the common femoral vein. So what we did now, we actually, what we did is we took a multi-purpose 4 French Judkins catheter and made multiple holes there and used altiplase at a rate of 2 milligram per hour to actually dissolve the clot in the thrombus, the clot in the IVC filter. As below the filter, the entire IVC was occluded, as we have seen earlier. Now we continued with our lysis for some time, and we, as usual, we keep these patients in the holding area and keep doing check angiograms every 4 to 8 hours, and keep monitoring the progress of thrombolysis and readjusting the catheters if possible. So post catheter-directed thrombolytic therapy for the right, femoral vein, iliac vein, external and common, and IVC filters. This was the result. This was the result which we got. We can see that the lysis was progressing well. A lot of the clot was dissolved, but there was still some bits of clots and chunks of clot trapped within the filter. And then we continued our lysis, and after some time we could see, this is probably after 16 hours, that the filter, the clots in the filter and the iliac veins and IVC had lysed. And then we went ahead and went crossover to deal with the deep vein thrombosis on the left side, which was involving the left common femoral vein, common iliac vein, and the external iliac vein, and also the superficial femoral vein. Again, this was a retrograde technique. We used the same catheter. We took a thermo wire, and with the little manipulation with which we go across the valves and place this catheter distally almost up to the distal thigh, and continued our lysis with altiplate in the same way. And this is the progress of lysis which we have seen over a period of time. It takes time, but actually you can see the profunda, profundal vein, which was totally occluded, and also the superficial femoral vein, which was totally occluded. And the lysis did work, although it takes a little time. And this is after 48 hours of lysis, you can see there is a good resolution of thrombus in the proximal veins, superficial vein, and the profundal vein. Then this is again a multi-side hole catheter. You can see we have drilled catheters as per our choice. And this is when we are injecting the contrast. This is just to see where the lytic drug would be delivered. So all this contrast which is coming out from the catheter into the clot, we can actually see where we want the clot, the lytic drugs to be delivered, and if the catheter is blocked or not. And then sometimes we have to reposition this. After we completed our lysis in the iliac vein, we actually found that there was a Mathew syndrome, which we suspected on the left side. And after we continued our lysis, we were quite sure of this, and we uncovered the Mathew. And then we took a balloon to actually, break the clot, continue with our lysis, and then treat the Mathew with a stent. Now this patient clinically improved. There was no residual edema on both sides. Actually, he came to us with edema on both sides after 5 days of 5 days of thrombolytic therapies. And after this 5 days, he was brought back to the OPD, and he was doing pretty well. The next question was to find out why did he have this, because this patient within a short period of about 15 days had DVT, pulmonary embolism, which was treated outside with lytic therapy, and then an IVC filter was put. They actually did not probably evaluate completely the cause of DVT and let the patient go on the molecular weight. And within a few days, the patient came back to us with bilateral iliofemoral DVTs, IVC, thrombus, and occluded IVC filter. And this is what we did. So this is the result which we got. And after this, we actually worked this patient up for the causes for hypercoagulable state and this sort of venous recurrence of thrombosis. There was no history of immobility or trauma or malignancy or previous DVT or hospitalization. And I told you about a week prior where he had a DVT and pulmonary embolism and IVC filter and lytic therapy. And since this happened within the 3 days, we did the routine thrombophilia workup, which was his lupus anticoagulant was negative. The protein C was 153, which was normal. Protein S was normal. Antithrombin 3 was normal. Factor 2 mutation and polymorphism was absent. Factor 5 Leiden mutation was absent. But what we saw was that he had MTHFR, which is methylene tetrahydrofolate. This mutation was present, and what we have seen in our series now, we have got at least 7 cases where we find young ambulatory males or females presenting with DVTs, not only DVTs, but also arterial thrombosis. We had a patient who had an MI in 3 different settings, had an MI mesenteric occlusion requiring laparotomy and anastomosis, and also then DVT. So this was present, and we are seeing this pretty commonly in our population. And this patient was put on both, folic acid replacement therapy as well as vitamin B12 supplementation. So in conclusion, and also long-term anticoagulation. So in conclusion, venous intervention is one of is quite common, and it's an evolving innovation in the endovascular interventions. Thrombolytic therapy for acute DVT works very well, provided we use the right indication, right lytic drug, and we are patient to actually continue our lysis in the proper way with multiple cycles and repeated screenings. We can do this with thrombectomy devices. Sometimes it is faster, but thrombolytic therapy actually works very well alone. And if the patient is, if the time permits and the patient can afford, and there is no bleeding complication. The success rate is very high, but what is very important is that we should not only intervene only for pulmonary embolism, but intervene early for DVT as well to prevent post thrombotic edema complications. Try to uncover the cause. In here we had a dual cause. We had an anatomical cause of Khanna, and we also had a physiological cause of MTHFR mutation. So I'll end my presentation here and open this for discussion. And probably a lot of you would have similar experiences with young ambulatory people having massive DVTs and pulmonary embolisms.
Khanna sir, I think we are running very short of time.
Yeah, I've done that. It's finished.
I think we can invite Dr. Bedi to present his case, and then 2 cases we can discuss together.
Sure.
Yeah.
Dr. Bedi, sir.
Yeah. Yeah. So I hope you can see my slide.
Yes, sir.
Yeah. So I'm just going to present an interesting case that we've had recently, where the challenge was basically a 65-year-old gentleman, a known case of diabetes, coronary artery disease. He was post-PTCA 2018 and hypertensive, chronic smoker. Left foot rest pain since last 2 months, and then developed blackish discoloration of the left great toe and second toe, which kept on extending onto the forefoot. The previous history was that patient had undergone an intervention left iliac stent angioplasty was done on 4th of April 2016 with a left CFA to popliteal above knee bypass using the ipsilateral reverse late saphenous vein. Subsequently, in 2020, he had an occlusion, presented with critical limb ischemia. An attempt to recanalize the occluded FEMPOP graft was not really successful at that particular time. And this patient came to us earlier this year with dry gangrene of left great toe and second toe. The left foot was cool. The sensation was decreased over the foot. Movements are restricted at the toes and no calf tenderness. Popliteal and distal pulses were absent. And on duplex and CT angiography, it was showing a complete occlusion of the left SFA and the bypass, which was done earlier, the FEMPOP graft with reformation. That was graft was occluded, and there's a reformation of the P1 segment of the popliteal artery. And there was a CTO of P2, P3 segment of popliteal artery again with reformation of proximal ATA and a diffusely stenotic tibioperoneal trunk with CTO of PTA and mid-peroneal artery. So he had multi-level disease, and on top, to add on to the troubles was basically he had a right external iliac artery occlusion. So the challenge was basically, this patient who presented with the left lower limb Rutherford category 5 CLI, occluded previous FEMPOP bypass graft, failed attempt to recanalize the SFA, also the native SFA also, as well as the graft, and the BTK disease. And one more thing was his ejection fraction was just about 20 to 25%. So the challenges out here was you couldn't take a contralateral access because here we had to do a multi-level reconstruction. Out here you had to go from the common femoral into the SFA, popliteal and distal segment. So right iliac was not really available. Going transbrachial would have been a challenge because none of the hardware would really reach below the knee level after that, because there's hardly anything available out there in catheters and all. The third challenge was the low ejection fraction of 20 to 25% with a high risk for GA or SA. Therefore, an open or a hybrid procedure was not really the best choice in such a case. So here what we had to do was improvise a little bit, and what we did was use an auxiliary artery for the puncture rather than using the brachial artery, which we conventionally use out here. And the whole thing could be done under local anesthesia. So the first thing was to recanalize the left fempop bypass vein, do an angioplasty and stenting, and then follow it up with balloon angioplasty of the left popliteal artery and the ATA. So this is just to show you the first of the angiograms out here. The iliac stent is completely patent, but beyond this, down below, you can see that there's just a streak of contrast which you're seeing out here, but rest everything else, the SFA and the fempop graft is completely occluded. And then, of course, this was the reformation of the proximal popliteal artery. It was like an isolated popliteal segment. And then again, the CTO of P2, P3, and reformation of the proximal ATA, which was seen out here. So just to show you a short video out here, a proximal anastomosis here, what we did was crossing with an 035 Terumo, we tried to get across into the saphenous vein graft out there. And it was with some difficulty that we could enter the graft gradually, and we could feel that, okay, now we've entered the graft. Once we were able to get across the catheter, we took a balloon, and then after that, we did a POBA with a 520 100 millimeter balloon, went all the way on top, did that particular part, doing a complete POBA of the entire segment of the saphenous vein graft, which was there. There was a proximal tight stenosis, as you noticed out there. And then, of course, there was a recoil. As you can see that the whole lesion is again recoiled. So then we decided that we got to put in a stent out here. So we used a Selfex Absolute Pro stent 5150. And as you can see that proximally, again, you still have residual lesions. So we had to put in an extension, a protege of effect 6x200, because we really had to cover up a long lesion out here. So this was done along with the second stent, and then ballooned the segment out there with an Armada 5x200 balloon. Ballooned all the way after putting in the stent out there. And now you got a straight line flow going all the way down into the distal segment. So then it was not really over, because now again you had to catch hold of the CTO of the mid-popliteal area. The mid-popliteal artery again went down with a Terumo, then with a command ES wire, in fact, an 014 system out here. We had to get back because very, very thin vessels out here. And then manage across to get our wire into the anterior tibial artery, as you can see out here. So we did the proximal segment out here with a 4x100 millimeter balloon of the popliteal segment out here. Entire thing was nicely ballooned, in fact, twice over. And then we had a good runoff into the anterior tibial artery, and you can see that there's a good flow which has gone across towards the ankle. So this is what was done, a 6 French long sheet, 6 French, we started off with a 5 French sheet and 6 French long sheet. Terumo, stiff Terumo was used, an 035 wire for getting across down below, and a supracore stiff wire was used for deploying the stents. The catheters that we used was an MPA and a vertebral, and then of course the hardware which was used a 5x200 and 5x200 and a 4x200 balloons. And 2 stents were used, and we were able to come back home and dry. On post-procedure, this is what the thing was. The left forefoot was amputation. Amputation was done after 10 days, and you can see a good bleeding out here. And the ATA flows were almost more than 80 centimeters, 70 to 80 centimeters per second. Flows were there, and this wound healed. So this was a short case which I just wanted to present. Thank you very much for the opportunity. So this was the challenge, was basically the approach in this case and to address all the lesions with the limited hardware. And just to share with you that this year we couldn't do the EVL in February, but we are planning to do the first live hybrid conference on 13th and 14th of August in Delhi, which will be participated. We'll have only limited physical participation, and rest will be all on virtual mode, and we will be doing this meeting with multiple centers from India and all over the world. So thank you very much for the opportunity. I bring warm greetings from my department, Institute of Vascular Sciences. Thank you.
Thank you, sir. Both the cases were nice. May-Thurner syndrome by Dr. Khanna, sir, and long segment multi-level disease management by Dr. Bedi, sir. We invite all the panelists and chairpersons to put their comments.
So Bedi, just a small doubt from my side. See, when we treat these graphs, what are the kind of patency you've been having? I mean, because the immediate result looks fabulous,
Yeah.
And we put these Everflex or any of these kind of nitinol cut stents. These are laser cut. And do you have any experience using the Supera, which is knitted? Because I just wonder, because we need this to salvage the limb, but how long will it last actually?
So again, I think we come to the same point that we were discussing before we left off the discussion out there. That here we had a bailout, so we had to come back and address this patient. We had to fix up in some way to salvage the foot, otherwise he was landing up with a below knee amputation. And that too with a low ejection fraction. Stent is definitely not the first choice. As you saw, we always try to balloon out these veins. Now this vein bypass basically lasted for about 4 years or so till it went down. And we wouldn't have probably touched him again with a barge pole if he was doing all right and there was no tissue loss out there. But since and there was already a failed attempt at native artery recanalization, probably, and we have done in a few cases where the vein graft gets occluded, we have been able to recanalize the native artery. So deploying a stent into the vein was definitely not the first choice. Probably it was a bailout situation because as you saw, the moment we finished ballooning the vein, the whole thing went down again. We deployed the stent distally and we thought that maybe we'll be able to get out again. Again, it was the proximal vein was just not. So these veins, sometimes they become very, very fibrotic. And that is where the challenge is. Once they become fibrosed and all, you don't really have much of a choice except deploying a stent. And as we said that the ultimate aim in this particular patient was to get the wound to heal, which we did manage to achieve out here. The long-term patency is basically for these patients, of course, it should work well in the sense because once the wound heals, the patient is able to walk and all. Then there should not be too much of a problem with these patients.
Bedi, can I ask you one question?
Sure.
In such a situation, this is a venous graft, except there is a possibility of thrombosis in that graft. Wouldn't it have been easier to try the native? I agree somebody else had tried it.
No, we also tried it, Gireesh. We also tried it. I edited out some of the images, but we did try to get across into the native artery. But then we were just not making anything because the wire just wouldn't slip into the native artery. As you saw initially, I showed you, it kept on slipping into the profunda. And unless and until you see here, we could have normal cases. What we do is we do a retrograde approach. Now here, the challenge was that you don't have any.
You didn't have anything. But one point I agree with, we also tried to go back to the native artery so many times, Actually, Gireesh, we do the same thing. We have finally attempted the native artery and stented it because it's true. It's a bad, there's nothing to lose because there's nothing else to offer.
No, we have a very low threshold for, doing a retrograde, entry. And here in this case, because you had only one artery going upstairs out there, you don't want to jeopardize that also putting in a wire across into the anterior tibial. And then you land up with a lot of problems because then the foot is gone and he'll land up with a below knee amputation. So normally we have a very low threshold. If out of the 3 vessels, 2 vessels are available, we would have probably done a retrograde approach and sorted this out.
Dr. Khanna, sir, and all others, sir, how many times we put venous stents in acute May Thurner? This was a subacute to chronic presentation, like.
See, that is a guideline, right? If you do you post dilatation, if you find there is a gradient or if you find there is the dilatation is suboptimal and there is a stasis of flow, you have to stent it. And in our environment, in our experience, at least 70% of them get stented, or maybe even more. We stent a lot of them, actually, really.
I have a question. Obviously, in such situation of a venous thrombosis, thrombolytic therapies, the treatment of choice, what happens to their lungs? And do you do a pre-procedure lung perfusion, maybe a CT to look at where does it go and what happens to their peer pressure? What's their long-term results in the lungs? Because that is a worse disease because it, of course, you could treat it nowadays with endarterectomy. But what is the usual thinking of the group here in situation? Do you do a pre-procedure CT scan scan to look at. What happens to it post-procedure, and what's the peer pressure in such patients?
So I think the most important part is that probably we always do a 2D echo for these patients, Sanjay, as a routine. But we don't really do a CT pulmonary angio in those cases unless and until there's a documented history of pulmonary embolism. I don't think you're really justified in doing that. And but we look at the 2D echo. If that is suggestive of anything, some kind of a dysfunction out there, then of course, definitely it'll be a good idea to do a CT pulmonary angio and assess the arterial circulature there. Yeah.
Exactly
I have a couple of questions also. Yeah.
No, I just said we also do the same thing. We have a baseline 2D echo, and then we do the procedure and we follow it up. But if there is nothing significant, we will just leave it at that. Because even for a pulmonary artery thrombus, the treatment is basically the same. You fragment lyse and it goes to the periphery, and they do reasonably well. So
no,
you wouldn't chase it.
We should not worry about thrombolytic therapy because it is not chunks which goes. It's just a question, and I don't think there is any doubt that thrombolytic therapy is the answer for such patients. Even if you have a embolism, they do very well. But what is the long-term results on these patients? That is my thinking. Just a thinking.
So I think unless and until they are thrombosing recurrently, they are throwing embolus and all this sort of thing, then it's a different thing. But by and large, if you've sorted out the problem, as in this particular case, by putting in a stent and all, I think they should do pretty well as long as you keep them on anticoagulation for an optimum period of time and keep them on antiplatelets. I think they do very well. I think it's a very, very small subset of maybe 1 or 2% of patients who would probably have a recurrent pulmonary embolism. And probably then we need to evaluate further why they are developing this kind of a recurrent thing. But otherwise,
we use a lot of angiojet now. I mean, we would combine the combination and technically would be a little different, but otherwise it's the same thing.
Do you still have IVC filter patients?
IVC filter. That was. What about the use of IVC filters?
Yeah. I think
this one that has been going for 5 decades. I think this patient useless devices that keep on going on. I think
one thing
should take it out.
That should be stopped completely.
Yeah, couple of points which were there was that this patient initially was subjected to placement of an IVC filter and given systemic thrombolysis. So I really don't understand what are the indications for both of them. There is something which probably difficult to fathom why that. And I was a little intrigued if I can ask Dr. Khanna about this particular part about the approach of going first. Declotting the part in the common iliac vein and the external iliac vein, doing the rest of it later, and then cross over to the other side, because one is a little concerned about the valves on the other side, because you're going retrograde from right to the left and all, and the possibility of damaging the valves with a catheter and wire and lysis and all are pretty high. So why not go from the ipsilateral side to doing a popliteal puncture?
Which is the standard of care.
Let me answer this. The first one is, this patient presented in 3 days. He was, lying. That time when he presented to another hospital, he had a DVT, pulmonary embolism, and that's where he was lysed with systemic lysis, and an IVC filter was put, and he was put on low molecular weight and discharged. 3 days he developed this, and in this case, actually the filter worked and was life-saving. And he had there was a clot inside the filter and the entire IVC was blocked. So my first thing was to go ahead and declot the filter and the IVC, which is the common pathway, and then go ahead, because I had approached it from the right side, and the right side approach was, it was like, it was not, that I knew that there was a clot. I knew there was a clot on the left side and they had lysed it, so I went from the right side. And once I punctured, I found that no blood was, the dye was not going forward. And then I did an echo and find an angio and found that there was the DVT, which was involving the femoral vein, iliac veins, and also the IVC. So I didn't want to change at that time because the patient was on anticoagulation, and I wanted to clear this path and the IVC and then go ahead from the same puncture to the other side. Now I agree, if I knew the things earlier, I could have gone from the popliteal stick and lysed from below and above both. But once the patient was on full...
no, but Dr. Khanna, just to interrupt you, you would have done a Doppler or a ultrasound before you started, right? Actually, so whatever you say you discovered, I mean, you would have known it beforehand, right?
Because this patient came to me acutely And what I thought was, that the IVC filter I saw that was blocked. And normally at our place, we don't do the Dopplers. It is done by a different set of ultrasound or the non-invasive cardiologist. And surprisingly, they did not comment that there was a clot on the right side. So we did go back to them and said, and they actually, I don't know what they saw, but it was a wrong reporting from their side. And we were surprised on the table because it was never mentioned that on the right side that there was a clot in the femoral and iliac vein. In our hospital, it's done by two non-interventional invasive cardiologists who only do this sort of work. So how we got to that place. Otherwise, if I had to do it, I would have gone from the left side and did everything from the left side.
Dr. Milan, sir, I think you can start your presentation.
Tarun, can I comment?
Yes, sir.
Please. Sir, Dr. Bedi, sir, regarding the saphenous vein graft stenting, is there any concern about, say, 4-year-old saphenous vein graft and its atheroembolism distally?
Sorry?
So is there any concern about embolism of a thrombosaphenous vein graft in your case, and any distal protection been tried?
No, we didn't really see because basically he had a multi-level disease. You had an isolated popliteal segment in the proximal part, so it couldn't have really gone anywhere. We could have always used some bit of thrombolytic therapy if required, but this was a vein which was completely fibrosed. It was not really a distended thrombosed vein. So this was the bypass was done almost 4-5 years back. So that is why over a period of time, because when we do a Doppler, we always do intraoperatively, and of course pre-op we always do a Doppler. So in Doppler, you can make out whether the vein is distended with thrombus or whether it is basically a fibrosed vein. In this case, it was a fibrosed vein. So we know that it can't really, throw any kind of material down below. And the second thing is you already have multiple filters already lying out there. You have the P2 segment, which is occluded. You have the P3 segment, which is occluded. And then you have the BTK TP trunk also occluded. So that's why the risk of atheroembolism is very low in this particular case.
Like a comment from Dr. Khanna regarding say use of angiojet for such a high load of thrombus across the IVC and both the iliac vein, as you have done thrombolysis for a long time, very high doses for say first initially for the right side followed by the left side.
If we had an angiojet, we would have used it. It would have we would have used a thrombolytic therapy following angiojet because it doesn't take out the clot completely. And we were not sure whether there are emboli in the pulmonary area also. So it would hasten the process. It will shorten the duration of thrombolytic therapy and also the quantity of thrombolytic therapy. I have a question for Dr. Bedi. With a soft thermo wire, do we really damage the valves if we go retrograde? Because, that is the thing which we do for recanalizing a lot of central veins and the arm veins when we go from below. And in the corridor, the soft thermo wires, if you can go very easily because the valves are in the open position already when there is a thrombus. You are not actually going or perforating the valve. If the wire goes smoothly, why not to take the wire and just pass in a catheter? Because these are
basically it's not the wire which does the damage, it is the catheter which does the damage. Because you're going along with the catheter. So that is why they're always concerned that you're going to be taking out the catheter and probably trying to suck out thrombus and all. So generally we always go. Yeah, Dr. Mathew.
Dr. Khanna, what Dr. Bedi and we are trying to say, in general, we would all go from the popliteal. This is a rather unconventional approach that you've done, but you managed to succeed. So I guess it's fine. But in general, since it's a meeting, a lot of people are watching. The protocol that is followed always is you have to do a Doppler, an ultrasound, make sure you know the pathology, the extent of the thrombus, and the puncture is in the popliteal veins, and you ascend that way in the direction of the flow, and you start from the top, come all the way down, and you take out. And in our center, we have completely stopped purely chemical thrombolysis. It's a combination, like what Dr. Khanna said. We would debulk the whole thing with angiojet. It's very, very fast, and then we will lyse it. But like Dr. Bedi, he finally got a good result, so it's okay, right? I mean, it's sometimes I realize that many approaches work, so it's little unconventional. That's why probably the discussion,
So, sir, take-home message is antegrade thrombolysis, not the retrograde ones in the venous system.
Yes, that's right.
Yeah. Dr. Milan, sir, please start your presentation.
Yeah, okay. Good afternoon. Am I audible and visible?
Yes, sir.
Okay, fine. So I'll go ahead. This is a novel use of intravascular lithotripsy for coral reef aorta. My case is slightly similar to what Dr. Sanjay presented. He used IVL for preparing the vessel. My case was for as a IVL use as a destination therapy. So basically, coral reef aorta was first described in 1984. Basically, it is a rare disease of heavily calcified exophytic plaques in the supra, juxta, or infrarenal aorta, causing significant luminal narrowing. Pathophysiological basis for coral reef aorta is not completely understood, but it is possibly there are low serum levels of calcification inhibitors like Petuin A and GLA MPG, which may be contributory. So basically, heavily calcified exophytic plaques in abdominal aorta causes significant stenosis, which leads to visceral ischemia, renovascular hypertension, and claudication. And surgery or percutaneous intervention with stenting carries high risk of complications and mortality because of heavy calcification. So my case is a 67-year-old female who presented with history of hypertension since 4 years, needing almost 5 antihypertensive drugs, still used. BP used to be around 160 to 180 systolic. She had exercise limiting claudication of both low limbs for almost 18 months. She was hypothyroid, well controlled, dyslipidemic, on statin, no diabetes, no history of tobacco use, or no adverse family history of coronary artery disease. She was obese. She had weak femoral pulses. Upper limb BP was 160 systolic, lower limb BP was 80, and she had a systolic groove in umbilical region. Her hemogram showed hemoglobin of 10, creatinine was 1.42, eGFR was 42, ECG and echo were normal. Her USC abdomen with bilateral renal duplex Doppler showed significant narrowing of infrarenal aorta, which increased flow velocities in aorta as well as both renal arteries. This was her angiography, coronary angiography was showing insignificant atherosclerotic disease. And she had a bilateral, this juxtarenal aorta was calcific, and she had bilateral critical stenosis of both renal origins, with significant narrowing of infrarenal aorta also. So management plan for coral reef aorta is either surgery or endovascular intervention. Surgery is in form of thromboendarterectomy, interposition graft, or axillary to iliac artery bypass graft. But it carries a very high operative mortality of almost 10%, and post-operative complication requiring corrective surgery is almost 15%. If you think of endovascular intervention, it can be plain balloon angioplasty, or you can put bare metal stent or cover stent if there is no major visceral branch arising from that disease segment. Sometimes coronary aorta is just near the diaphragm or just above the aortic bifurcation. So in that case, there are no major branches. You can put a simple stent like Endra or anything. But when it covers like this paravisceral area, then you need stent graft with chimney or small case stent graft to protect your visceral and renal arteries. So that was our case. So I thought that let us try IVL assisted balloon angioplasty. So I decided to assess the extent of calcium by endovascular intervention planning. So I did a non-contrast CT abdomen. So this is the sagittal view, heavy calcification in infrarenal aorta. This is a coronal view. And if you see short axis transverse view, almost entire lumen was completely obliterated by coral reef calcification. Diameter of infrarenal aorta at this point was around 12 millimeter. So plan was to do intravascular lithotripsy assisted balloon angioplasty for coral reef aorta with bilateral renal artery stenting. So I had taken 2 XS, left radial artery, 6FGR guiding catheter was introduced. Through right femoral artery, 7F renal guide catheter was introduced. Largest peripheral IVL M5 catheter diameter is around 7 mm. Our aorta was 12 mm. So I thought of a concept and philosophy was like they decided to use two parallel hugging balloons. One was IVL balloon, which was 6 millimeter, and another was a plain balloon, which was diameter of 9 mm. So these two balloons will remain like this. And aorta is 12 mm. This is blue is the IVL balloon, green is the plain balloon. So by this formula, effective diameter will be 0.82 into D1 plus D2 as described by Rao in 1987. So using this formula, I used two balloons. One was IVL balloon, another was plain balloon. And then theoretically, as the principle of physics, once shock waves are generated, they will pass through IVL balloon as well as plain balloon, which is also filled with simple 50% diluted contrast. And ultimately, shock waves will be prevented by calcific intimal and media. So intimal and medial calcification will prevent or hit with the shock waves. Plain balloon also will transmit this shock waves. So there may be some loss of energy, but you can always change the position of balloon in different ways to give different cycles, and you can try to cover entire aorta. So that was my philosophy and concept, and this was my destination therapy. I was not intending to use any stent because of financial reason as well as to avoid chimney and snorkel. So aortic gradient was 80. This was suprarenal aortogram. I did initially left renal stenting because EGFR was less, so wanted to protect at least one kidney and start renal perfusion. Infrarenal aorta was angiograms was showing almost near complete occlusion of infrarenal aorta. Heavy calcification was there. So initially, to allow IVL balloon to pass, I did redilation with PTC balloon 3.5 mm, and then 6 mm shockwave M5 catheter was introduced, and you can see these bubbles, and this we see in coronary and peripheral arteries also. So initially it was 2 cycles were given here, and then I used 2 hugging balloon. One was 6 millimeter IVL balloon, and another was 9 millimeter plain balloon, and at different levels 6 cycles were of shocks were given. Renal stent got deformed at that level, so I did again kissing balloon dilatation of left renal stent. So that was okay. Ultimately, even right at the end, right renal artery also was stented with a 6 millimeter stent, and this was the fine result. And gradient, which was 80 pre-procedure, was almost obliterated, and this was the final result. So there were 2 stents in renal, and this was a plain balloon angioplasty using IVL. So there was minimal intimal flap and dissection, but ultimately a 12-month follow-up. Now it was done in last June. She came yesterday only. Her present ABI is 0.94. She is asymptomatic with well-controlled blood pressure, with reduced doses of antihypertensive. There is no claudication. She is able to walk around 2 kilometers a day. Creatinine has come down to 0.81, with EGFR, which was around 42, is now 72. Doppler shows patent renal stents with velocity of 70, and there is some 40% calcific narrowing of infrarenal aorta, but she is free of any kind of claudication, and she is able to walk. This case was already published in European Heart Journal case reports last month. And what are the conclusion and learning points? Coronary aorta is a rare disease involving juxtarenal aorta and can present with hypertension, visceral ischemia, or claudication. Surgery for coronary aorta carries high mortality, and perioperative complication rate is also very high. IVL is a safe, effective, and simple modality for treating calcific peripheral as well as coronary lesions that is now proved by various trials. And when CRA is juxtarenal with no safe landing zone for safe stent grafts, IVL may be a safe, less complex, and effective alternative to use of juxtarenal aortic compared to juxtarenal aortic stent graft with multiple chimney and snorkel stent grafts. Then this is the first report of novel use of IVL to treat CRA. Thank you.
Thank you so much, sir. It was an excellent case, bilateral single sitting renal artery intervention. I think we invite comments from Dr. Bedi sir, Dr. Gireesh sir, Dr. Mathew sir.
I think that was a great case. I think, Dr. Milan, compliments to you for managing it so well. Just one point which I wanted to make out when we were doing the ballooning of the infrarenal part. You had already deployed the renal stents and you did not keep a wire. Were you a little concerned that you might just, push
what I want to know.
Something out there into the renal artery or cause a dissection proximally?
You are absolutely right. Actually, one wire was there in right renal artery also, right renal artery. And so 2 wires, and it was 6F catheter, and I had introduced 9mm balloon also. So there was a little bit crowding there. So I had to remove because there was too much of friction.
Right.
No, do you think you could have just left the wire and done the renal intervention? Sorry. No, do you think you could have just left the wire and done the renal stenting as a last procedure? I would have approached it that way, because I would have left the wire in and finished the outer, then completed the renal stenting. The second question, why exactly did you stent the right renal artery? I couldn't really understand that reason, because the left was a definite stenosis, which was critical.
Right also had 90% stenosis.
It is okay. What I saw, the image I saw, I can see.
Both were
because normally I feel it's very simple to have 2 wires to start with and complete it and then come ahead and stent it. So that's the last procedure.
Dr. Cherian, I think that would be, it's a wonderfully done case and your patient is fine, that's fine, that matters. But then the sequence of action should have been 2 wires in both renals, work on the aorta, stent the aorta, if you have wall stent, whatever. Come back, stent both arteries and don't intervene after that.
Yeah.
Because that should be last, because otherwise you will deform the stent all the time. It was very expected that if you put a balloon, and he's lucky that he went in again, because it's very difficult.
Yeah, very true. Honestly, I think that if you deform the proximal end of the stent, sometimes it's crushed. You can't even go through. Sometimes balloons perforate also,
And it's a balloon expandable stent. It's a very rigid stent. So that's why it's much more difficult to manage.
Dr. Bedi, just one question. Can there be a similar situation suprarenal also in the descending part of the aorta, coral reef aorta? Because I had one patient who had coarctation of aorta basically. And when I put first time wall stent, and then he was okay for say a year or so, and then he again comes back with accelerated hypertension, and his reef had ascended upwards towards the subclavian. So I had to redo ballooning, and then he stayed. But then in the long term, I lost the follow-up of that patient. He died of probably an accelerated hypertension and LVF, and then he was fed up of his hypertension. He had some. So in that situation, if it starts ascending up, I went through the literature and it had said that even aortic replacement surgeries have been done. Is it the way that actually coral reef aorta, and coral reef aorta, by the way, doesn't restrict to infrarenal. It can be again the entire. So, and the treatment for such situations would be a replacement of aorta rather than any intervention finally.
See, now this one IVL has come in a big way, and that is showing promising results. Otherwise, before that, the only choice was basically, the only thing that you can do is put a cover stent and just disrupt the aorta. The only endovascular procedure that you can do is disrupt the aorta. You put in a balloon after putting in a cover stent. We call it what we call the paving and cracking technique, where what we do is we first put in a cover stent out there and then explode the cover stent so that even if the aorta ruptures also in that segment, it doesn't really, it disrupts also, but doesn't cause any problem. So that is one technique, but otherwise, primarily the long-term results are better with an open surgical procedure, doing a bypass.
I think it's an excellent discussion going on. We can't hold that discussion for long. There's 4 more presentations to go. I invite Dr. Gireesh sir. He drove from Nashik to Mumbai to present this case. Sir, please start your presentation.
Yeah, just give me a second. Can you see me?
Yes, we can see.
And
we can hear you actually, not see you. Yeah, now we can see.
Okay. So I'm just going to present one of the difficult cases that I've had. So this is a simultaneous treatment of an embolic popliteal artery occlusion with arteriovenous fistula. So this is a 61-year-old male. In 2002, had a history of right lower limb claudication, swelling in the posterior aspect of the right knee, Doppler and CT showed a popliteal aneurysm. Surgical repair of the aneurysm with a graft was done at that point of time with a distal embolectomy. Then he came with a history of sudden onset of claudication 8 years later, and the patient had hypertension, which was for 5 years controlled on medication, and he had 3 instances of coronary angioplasty 3 years ago, 2 years ago, and 3 months ago. His right popliteal PT absent, and right foot was cooler than the left. Doppler in August 2009 showed a normal flow through the graft and popliteal segment. The hematoma in the posterior fossa was compressing the distal popliteal artery and poor dampened distal flow. The CT angio at that time itself, after the Doppler, showed a focal thrombus in the posterior segment of the graft, causing about a 60% stenosis. A focal tiny thrombus at the distal end of the graft, and prominent peroneal artery with peria fistula. So this is just the CT angio findings. You can see that there is a AV fistula on the left side, and on the right side you can see that there is a thrombus there lying on the posterior aspect of the graft. This is the surgical graft. And if you see on the ultrasound also, on the left is the angio showing that thrombus, and you're seeing that large hematoma that is there in the posterior aspect of the popliteal artery. He was lost to follow-up for 6 months and then presented in 2010 with worsening claudication of the left less than 100 meters. We did the ABI, and if you see on the right side, the ATA territory was 0.47 and the PTA territory was 0.38 and a normal ABI on the left. So we took him up for angio, and this is the angio what we find. Now he has come with a completely, totally occluded popliteal artery. And if you see distally, this is the DSA picture. You're seeing an early draining vein. So there, as I said, there was a fistula. That was what was causing the early draining vein lower down. And the distal circulation was very, very poor. So we decided now, let's see. So we passed the wire. Wire went down pretty easily. Not too much of a struggle. And you can see that there is a thrombus there sitting in the popliteal artery. So we decided that we will thrombolize him first. So we gave RTPA 10 milligram bolus, and thereafter we started an infusion of RTPA into the popliteal segment. And after the thrombolysis, we took the patient up for angio, and we saw that now distally at least there was no thrombus. And even in the popliteal segment, I have not shown all the pictures to show that the popliteal was also free of thrombus, but it had a narrowing. So this you can see the distally in the peroneal. So I presume when they did the embolectomy during surgery, they had caused some sort of an injury to the peroneal artery and developed a AV fistula. So once we saw this, we said, let's coil the fistula. So we went into the artery and then started coiling it. This is the first coil going in. We put a second coil. And then we put a third coil. So once we coiled it, the flow hadn't stopped, but I was pretty sure later on it would stop. So we continued with the intervention. And we got the, now you can see that there is no flow in the mid-popliteal segment.
दर्द बहुत हो रहा है ना? कहाँ मम्मी दिखाइए?
And then we decided we'd stent it with that time the Viaban was available, so we stented with the Viaban. And you can see that there is a narrowing at that segment, which we ballooned with a so this is the angioplasty. And now if you see after the angioplasty, we are seeing that there is some filling defect. I would suggest whoever is talking on the, can they please mute it?
Atul, can you see there is some technical difficulty?
So, sir. Done so. Yeah, please, sir, continue.
It's already muted.
Continue.
Okay, thank you. So now if you see the distal circulation, you can see there is a filling defect at the popliteal bifurcation. So I was pretty sure that this is not a thrombus now. It's a plaque that has gone up. Now, what do we do with such a situation? The plaque, normally we see that even if you do a suction thrombectomy, it doesn't come out. We had one option of whether to do a surgical. But what we said is, let us give it a try. What I did was put a wire in the anterior tibia and put a wire in the posterior tibia and inflated two balloons in the anterior tibial ostium and the posterior tibial ostium and flushed that plaque a little down. So if you see now, the plaque is flushed into the tibioperoneal trunk. Once I've done that, I removed this wire from the anterior tibial, kept the posterior tibial wire, and took the wire into the peroneum. And if you see here now, I'm using the balloon and I tried and pushed the plaque into the peroneum because I knew in any case we had to close out the peroneum. And now you can see the picture here that I have gone and entered into the, I'll just go back again once more and show you. If you see this picture, you'll see where the the posterior tibial is. So the tip of my balloon has gone beyond and it has entered into the peroneal artery. And then this is the final picture of the post-intervention. I have not shown you the popliteal because the popliteal was clean. And oh yeah, you can see the popliteal here in the second image. The third image showing you the plaque in the peroneal. Now you don't see the AV fistula filling and the distal circulation, which is much, much better. His rest pain went, his discoloration of the toes went, and then the patient, after 2 years of follow-up, was lost to follow. Thank you.
Hey, Gireesh, honestly, congrats. That was absolutely amazing, out-of-the-box thinking. Nobody, I think, has used a balloon to shove a plaque down, That's really, really amazing. Like, you use the balloon like a bulldozer to take muck and put it on a dead end of a street, That was really smart thinking, because we would, seriously, we know this happens. Sometimes these plaques keep moving up and down. To actually use a balloon, push it, pack it into a vessel that you blocked beforehand, that's really smart.
The
once in a lifetime case.
Yeah, other point was that the other way to do it was put 3 wires and use the central wire to push the plaque. But I had only a 7 French sheath and it could not take 2 wires and a balloon. That is why I flushed the plaque into the tibioperoneal trunk and then used that 2 balloon technique.
Yeah, it's very smart, seriously. And of course, you already had knocked the peroneal off. Even otherwise, using one peroneal was okay.
Yeah.
Gireesh, the plaque had gone into the ATA.
Pardon?
Suppose the plaque had gone into the ATA rather than the TP trunk.
Then he wouldn't have shown the case.
No, but the plaque, I'll tell you what it was. The plaque was big, pretty big for it to go into ATA. So that is why it got stuck at the popliteal bifurcation. Now, because it was stuck in that popliteal bifurcation, I took the chance and said, rather than opening him up, actually this patient was with a Parish's patient. And I could have always done a surgical embolectomy, but we just tried this and rather than avoid surgery, and by already that was a very hostile territory because of the hematoma plus the previous surgery. That's why we tried on.
No questions on that. I think we just take the ATA balloon first. It will probably go towards the.
No, but see, no. When I had put the balloon in the ATA and in the PTA, it couldn't go into the PTA. It cannot go into the ATA. It has to be, if at all, in the peroneal or in the tibioperoneal tract.
Right. No, you had kept the balloon inflated. I mean, I don't think it would have gone. But honestly, I mean, it's really out of the box thinking. Very smart thinking.
Right. Thank you.
Sir, Dr. Manoj, you have to present your case now. Unique experience, IVL 2 cases.
Yeah, esteemed Chair, it's a wonderful session that we are all looking ahead, and multiple opinions as well as expertise being expressed on the peripheral cases due to the unique experience. It was thrilling to listen to pushing the plaque into a vessel which was perhaps not required. It's a wonderful idea. So let me share my unique experience of a peripheral shockwave lithotripsy of 2 of my cases, along with my colleague Dr. Sundar Sudambaram from Kaveri Hospital in Chennai. This is an 81-year-old elderly gentleman who used to walk 7 kilometers with exertional angina developing, fast progressing to activities of daily living, multiple comorbidities, carcinoma of prostate, he has atrial fibrillation, emphysema, obstructive sleep apnea, underlying anemia, and CKD. He had a differential blood pressure values in both the upper limbs and lower limbs, which you could appreciate here. There was a lower limb pressure was 178, and the upper limb pressures were 78. So it's a 100 gradient at rest with feeble both upper limb pulses. I could not get a diagnostic catheter from the right radial artery across the occluded right subclavian artery, and subsequently he developed a heart failure and acute coronary syndrome requiring a mechanical circulatory support assisted high-risk PCI. And you could see that angiogram was done from the femoral aspect, and there was a very high calcified critical left main disease which required a percutaneous coronary intervention. Because peripheral arterial disease, a CT aortogram was done which showed a calcified complete occlusion of both the subclavian arteries and also porcelain aorta involving the visceral thoracoabdominal with significant to critical stenosis of celiac, SMA and IMA vessels. However, he did not have any kind of abdominal or visceral arteries symptoms. So these are the DSA pictures and also simultaneous similar angulated pictures of the CT aortogram, which shows a boulder of rock sitting at the origin of the right subclavian, just beyond the origin of the right common carotid. And that required to be opened up to create an access from the right upper limb for my angioplasty for this patient, because I wanted to use high bore devices like Impella and ventricular arterial ECMO devices from the lower limb femoral accesses. So as a stage 1 of the procedure, peripheral IVUS guided lithotripsy to the right subclavian artery occlusion was done, and 7F sheath was introduced in the right brachial artery, ultrasound guided. Bifemoral access were taken for cerebral protection. Initially, the 2 filters were positioned in both the carotid arteries, and then you could see the 7F sheath here from the right brachial axis. And with the Gaia wire, it was crossing the occlusion, followed by graded inflation of 3 millimeters OP and NC. And that's the 3 millimeters OP and NC, followed by 5 millimeter balloon. And then shockwave lithotripsy with a 7 mm into 60 millimeters peripheral medium-sized balloon with 300 pulses delivered. And then finally a 10 mm balloon inflation was done, and you could see that the patency was achieved between the subclavian artery and the innominate artery with equalization of pressures. So the medium-sized catheter was used, and it required a 7 mm is the maximum diameter, and it could deliver about 300 pulses. Goes over a compatibility guide wire of 014, which was used for this patient, and needed a 7F sheath compatibility with a working length of 110. And you could see that this was the image 24 hours after when the patient was taken for the angiography. Without a stent, the IVL had achieved a significant patency, which was well available for the access. And these are the peripheral IVL, peripheral IVUS images. You could see the after the 5 millimeters balloon dilatation, there are circumferential deep calcification all around, and there was cracks of the 5 mm balloon, followed by significant luminal gain after the shockwave lithotripsy, almost achieving around 9 mm. And finally, with a 10 mm balloon, you could achieve equalization of the pressures, and that shows the efficacy of the peripheral IVL balloon. Subsequently, the patient had an ECMO as well as the impella insertion, and he had a very good PCI, and he went back home. So the peripheral shockwave IVL applications for the upper limb artery occlusion makes a very successful device for treating the dense and stony hard calcified total occlusion, and is created access for maintaining the right subclavian artery for performing the MCS assisted complex chip PCI. The patent subclavian artery was also indeed necessary for this patient to allow the blood pressure recording, because almost always we can't record the pressures in the lower extremity during the follow-up visits of the patient. So hypertension management is crucial in any patient. And this is the first case of peripheral IVL and the coronary IVL together with the MCS supported facilitated chip PCI to be reported, and it's in the press. The second case is a 82-year-old lady who came with a recurrent refractory heart failure. She had 3 times admissions in the month of June 2020, and then subsequently in September 2020, and finally end of November 2020. And she was having acute dynamic mitral regurgitation, and finally convinced for a mitral repair with a catheter based. However, she developed a cardiorenal syndrome, progressive renal failure, and became anuric, which required a hemodialysis for continuously consecutive 5 days. Renal artery Doppler done on 2 occasions showed a normal flow, normal corticomedullary differentiation. She was unable to be weaned off from the ventilator support despite dialysis on a daily basis. Repeated COVID-19 RT-PCR was negative. She had a insignificant FFR, insignificant proximal LED coronary artery disease, and therefore ischemic cause was ruled out. She had a normal LV systolic function. She had a systemic hypertension, impaired glucose tolerance. She was in dual chamber pacemaker for asystole events that she suffered from. And these are the echocardiogram. You can see the torrential mitral regurgitation going into the pulmonary veins, and the pulmonary artery hypertension to the extent of 80 millimeters of mercury, showing a significant heart failure and a severe pulmonary artery hypertension, and requiring invasive ventilation from which she could not be weaned off. So this is an 82-year-old recurrent heart failure, acute dynamic mitral regurgitation with cardiorenal syndrome, normal LV function, progressive renal failure, and we could not wean off from the ventilator, nor from the dialysis support. So there was a clinical dilemma of persistent heart failure, non-recovering acute kidney injury, and requiring a daily hemodialysis schedule. So reluctantly, I coaxed them for a cardiac catheterization, and patient and family agreed despite the 82-year-old lady being suffering in significant comorbidity, and an invasive cath was done. And you will see that this patient creatinine at baseline was 1.1, subsequently going to 2 and 3.1, becoming anuric and requiring daily hemodialysis, urea building up to 110, which was quite reasonably okay at 57. So at day 12, she was remaining anuria with the 24-hour urine output was only around 36 ml. So I had getting access from the ultrasound guided access. She's a very obese lady, and it's not moving here. Okay. So this was the injection from the infrarenal abdominal aorta, and you could see a significant tortuosity in the infrarenal abdominal aorta. And the pressures there was 62 by 28 with a mean pressure of 41. And the pressures, the catheter above the renal arteries, the pressures were around 60 by 26 with a mean of 40. So there was no gradient across this acute tortuous segment, indicating it was a pseudo-coarctation infrarenal abdominal aorta. Between the upper limb and lower limb pressures, there was a pre-systolic gradient of 80 and a mean gradient of around 47 millimeters of mercury, indicating a significant obstruction a little higher up. And this is a CT aortogram subsequently done, which showed a much similar picture as Dr. Sanjay Mehrotra has shown us. Circumferential deep calcium all around in the mid-thoracic aorta, and also in the sagittal plane and coronal plane. You could see that distinct calcification with protrusion of nodules inside the mid-thoracic aorta. So you would see that in the subsequent images, sorry, yeah. So there is a protrusion of calcific nodule, and the mid-thoracic aorta least diameter was 2.8 millimeters. And therefore, this patient was taken up for a percutaneous intervention of the mid-thoracic aorta, and a 4 mm into 10 millimeters OP and NC balloon was initially dilated with a 014 guide wire, and followed by 7 mm into 60 millimeters shockwave lithotripsy balloon, initially a standalone shockwave balloon. After achieving a good luminal gain, patient had a Bedi balloon, which was a non-shocking, the regular balloon, and that was interchanged on the sides, on both sides from the femoral artery axis to have a more circumferential dilatation. And then you could see the change of the balloon positions of the shockwave as well as the non-shockwave regular balloon. And then patient had this is a post-IVL shockwave balloon where the continuity was established. There still will be shaggy irregularity, and then deployed a covered stent which was post-dilated. You could see that there was a very wonderful result with still the coarctation existing, pseudo-coarctation existing in the abdominal aorta. There was no pressure differences even after opening the mid-thoracic aorta. This was a 28 into 28 into 174 Valier Navion stent graft. There was equalization of pressures. She never required a hemodialysis thereafter. Creatinine came back to 0.68, and this lady recovered from recurrent heart failure. She was extubated and was sent home after 3 days of the procedure. These are the peripheral intravascular images of the aorta. You could see a protruding nodules here, and significantly narrowed with multiple protruding nodules in the mid-thoracic aorta. And this is the live images. And the proximal and descending aortas are shown here, which allowed us to do the measurements. And this is a circumferential calcification just beyond the calcific nodule. And these are the final images after the IVL. You could see the circumferential calcium is broken, and you could see the stent graft with the fabric gained and folded. And after the post-dilatation with the balloon, after stent graft, you could see the fabric, which was a little cramped and crumpled and constrained, has been well opened up, and you have a almost near normal luminal gain, which was achieved with equalization of the pressures. The follow-up of this patient, about 4 months later, she's meticulously maintaining the blood pressure. You could see all the blood pressure values are normal, and 130 to 140 systolic and diastolic of 70 or 80, and she never required any antihypertensives for subsequent to the discharge from this treatment. She's able to do activities of daily living and also do self-care. She's only on statin, aspirin, and amiodarone because she used to get paroxysmal atrial fibrillation. Her current creatinine, which is about a month back, is 0.66. So, friends, we've all been seeing coronal reef aorta in many presentations, and this is also another case of coronal reef aorta, which is a rare phenomenon of extreme calcification in the juxtarenal as well as suprarenal aorta, with appearance of growth akin to the hyperplastic bone jutting irregularly into the lumen. And these are some of the images, not from my case, but from the literature. And there are also reports of rapidly progressive kidney dysfunction in severely calcific stenotic aorta from Japan, where endovascular therapy was useful. Coronal reef aorta is an unusual possible cause of heart failure. It's also been described in the International Journal of Cardiology in the year 2014. Severe heart failure, prolonged pleural effusion, post-capillary pulmonary hypertension is a rare symptomatology revealing coronal reef aorta requiring surgical revascularization in those times of 2014 when IVL was not useful. Refractory heart failure and intermittent coarctation is also a presentation, and you would see that these are the kind of images that you would get after that. Let me conclude that coronal reef aorta is an extremely rare atherosclerotic and calcification of the aorta that can present as a severe post-aortic valve obstruction, which needs to be kept in mind in refractory heart failure and also acute kidney injury. Women tend to be more affected. It remains a possibility that we have to strongly consider in elderly patients with refractory heart failure, LV dysfunction, and also mitral regurgitation. Mid-thoracic descending thoracic aorta remains an inaccessible blind spot for most of the conventional bedside imaging in these sick patients who may not be able to be transferred to an imaging until there is in-house imaging like a CT. Debulking sometimes may be mandatory in some cases, as been reported in the literature where there was a peripheral aortoiliac coronal reef occlusions, as you would see here, required a rotablation. So some of these tools will become useful. However, we find that there's an effective tool in interventional radiology and cardiology that has been baffling us for all these years to find a solution for a dense calcified, rocky and stony heart arterial occlusions causing impasse in delivery of devices as well as effective reperfusion of the vessels. These cases illustrate how successfully and effectively any amount of dense and heavily calcified occlusions in the artery territory can be simply revascularized and access created in case necessary through a shockwave intravascular lithotripsy applications by these two cases of peripheral calcified occlusions. We could possibly give a new scientific terminology to this treatment, which is possibly the shockwave endovascular repair. And if you use the stent, a shockwave endovascular repair with stent, which could be a shower or showers. Thank you for allowing me to present this presentation. Thank you.
Thank you, Dr. Manoj. It was an excellent cases. Both the cases were very nice. And I think we can take on the questions on these cases later on. And next presentation by Dr. Charudutta Sambhaji. He's an interventional radiologist in Manipal Hospital, Goa. Dr. Charu, are you there?
Yes, yes. Just give me some time.
Yeah.
Is my slide clear?
Yes, sir. Clearly visible.
Yeah. Good afternoon to all, and thank you. So, after having looked at cases in the infrarenal aorta and the suprarenal aorta, we come down caudal to aortoiliac disease, heavily calcified aortoiliac disease. So this one, a 63-year-old male, a chronic smoker, came with rest pain and tissue loss. We attempted a sitting of angioplasty and stenting of the aortoiliac disease. In the first sitting, however, on table, we had a cardiac event with acute LV dysfunction. Prior evaluation of echo was normal, echo ECG. He underwent coronary stenting, and this admission went on with coronary care itself. He was readmitted for aortoiliac revascularization after a month. And this is his leg with a lot of tissue loss, foot with tissue loss. And this is the CT image showing a lot of calcification and calcific occlusion of both iliacs and distal aorta, more so on the left side. So we attempted to cross from both sides. We did cross easily on the right side. And then after crossing on the right side, we did place an infusion catheter and kept on lysis with tenecteplase at 0.25 milligrams per hour infusion for around 8 hours. But however, the attempt to lyse was futile, maybe due to outflow obstruction, and the lysis gave a poor result. Then we crossed from the left side. Initial attempts we did not manage to be luminal, and then subsequently we managed a luminal access on both sides. To allow passage for the lithotripsy balloons, we did 5 mm balloon plasties on both sides. And then subsequently used a 7 into 60 mm lithotripsy balloon. Is inflated at 4 atmospheres. 300 cycles, pulses were used spread out through the aorta and bilateral iliac arteries. So you can see that the initial inflation of the balloon is inadequate. And then subsequently, you can see that the 7 mm balloon has expanded to its full capacity at 4 atmospheres alone. So this was done across the entire length of the occlusion on both sides. Finally, a kissing balloon angioplasty with regular balloons at 10 atmospheres. And then we thought of putting a large size balloon mounted stent in the aorta to avoid long segments of kissing stents in the aorta. So this is the crimping of the large size balloon stent on the balloon. And this is an Andra stent. So to pass the Andra stent, we took a 12 French sheath access from the left side. The sheath was placed in the aorta, and the stent was positioned within the sheath at the desired position in the aorta. The sheath is pulled back to uncover the stent, and that is the balloon mounted stent being expanded into position. Then subsequently plastied to flare up the lower edges. We again passed 2 7 mm balloons into the aortic stent and did plastic to flare up the lower ends, and then placed 2 8 mm stents with a minimum overlap in the aortic stent. Subsequently plastered them again, and that was the result that we obtained after the flow on the left side is sluggish because of the large size sheath which is there in the left side. The sheath injection does show that there is no issue on the left side as well. So this was around about 1 month later, where we continued doing back pressing. His rest pain had gone, the wound is showing healing, and patient was able to ambulate with dressing. This is a little more recent video where he's able to ambulate around. And this is the present state of the wound. And the wound has healed with vac dressings without the need for any skin grafting. Thank you.
Thank you, Dr. Charu. It was again a very, very nice case demonstrating use of IVL and then aortoiliac casing endovascular intervention. We move to the last case, which is by Dr. Santhosh, cracking the coral reef in femoral artery. Dr. Santhosh.
Yes, sir. I'm just sharing.
Yeah, and in the end, we can discuss all these 3 cases.
Sorry, I'm unable to share because there's an error stating that you cannot start screen while the other participant is sharing.
Charu, you
stop
sharing the screen. Yeah, thank you.
Okay.
We can see your slides, sir.
Okay. So good afternoon, one and all. So it was a cracking session indeed, with lots of eminent speakers speaking about various situations. We have seen quite few cases of coral reef aorta. We come down to a situation in the femoral artery which is very similar to a situation in the aorta. So this was a patient, a 67-year-old gentleman from United Arab Emirates, who presented to us. He had a past history of diabetes, hypertension for 20 years. He was a case of coronary artery disease. The ejection fraction was 50%. He presented to us with a progressive bilateral lower limb claudication, more involving the calves, on the right side mainly, with a claudication distance of 20 feet. On examination, both his femoral pulses were palpable, but popliteal and below-knee pulses were absent. He was on aspirin and cilostazol for the complaints, but he had no symptomatic improvement with them. His creatinine was on the borderline, but his blood sugars were well controlled. He came to us with a CT peripheral angiogram which was performed outside, which revealed extensive vascular calcifications. Sorry, I don't have a MIP image, but we will see the coronal sections. There were at least 3 sites of critical stenosis in the common femoral, superficial femoral, and popliteal arteries. And this is the one in the SFA, and this is the one in the popliteal artery on the right side. According to the PARC classification, we classified it as moderate to severe calcification, which required a definitive therapy. There was also a focal short segment occlusion in the left distal SFA. It's not represented here. We took him for an angiogram to actually classify and characterize the lesions further. This was a fluoroscopy image of the same patient, which demonstrated chunky calcification in the region of the common femoral artery. We see the carbon dioxide angiogram. Corresponding position shows a significant stenosis, which is very eccentric, which is kind of lobulated and is narrowing the vessel to nearly 90%. We are seeing similar lesions also in the distal superficial femoral artery and the popliteal artery, which are eccentric calcified plaques. And correspondingly in the angiogram, we can see that there are quite a lot of lesions which actually are called stenosis caused by these calcifications, and they amount to around 90 to 95% in the distal SFA and the popliteal artery. So coming to difficulties with treating such extensively calcified peripheral vascular disease, we have seen in all the sessions in the current podium that there are issues like crossing the lesions with wires. There are issues with plain balloon angioplasty because it treats, it doesn't address the calcified part of the wall, rather it over dilates a non-calcified part of the wall and results in complications like dissection and rupture. We also have issues across joints because two lesions in this patient are across joints, and stenting in these portions may not be feasible. We also have an atherectomy option, but we have to remember that this option is only for treating the intimal calcium, not the medial calcium. So we decided to move on with a newer technique called the intravascular lithotripsy, which was termed as lithoplasty in the past. We placed a 6 French crossover sheath across the aortic bifurcation from the left common femoral axis. We crossed the CFA and SFA lesions with a straight thermo wire 035, and then the popliteal artery lesion with a 014 command wire. Then we went on to measure the reference vessel diameters, which were very important in selecting the balloon size. For the CFA, it was 4.1 millimeter. For the SFA, it was 3.1 millimeter. And for the popliteal artery, it was 3 millimeter. We can see the sizes are quite small compared to the reference population diameters, but we had to select our balloons based on these reference vessel diameters. So according to the DISRUPT PAD3 study, we took an oversizing of 10% of the IVL balloon over the reference vessel diameter. So we selected a balloon of size 4.5 millimeters for the CFA and 3.5 millimeters for the distal SFA and popliteal artery. So both these balloons were 6 centimeter long. Once the wire was across the popliteal artery lesion, then we inflated the IVL balloon for an atmosphere, 4 atmospheres, which is subnominal, to actually decrease the barotrauma to the normal vessel. We know the procedure of intravascular lithotripsy, how it works and how it generates the sonic pressure waves, and adequate contact with the vessel wall is necessary, and so the sizing is very important. And once the vessel wall is contacted by the balloon, then the sonic pressure wave selectively cracks the calcium rather than affect the soft tissues. So as we all know, the cycles are 30 pulses long, and you can actually go up to a maximum of 180 pulses per catheter. So 6 segments can be treated if each of them require a 30 pulse cycle. So here we have fluoroscopic images of the inflated IVL balloon in the popliteal artery, the distal SFA, going up to the proximal most lesion in the distal SFA. We have used the same balloon for 4 different segments for 4 different cycles of 30 pulse each. Once the procedure was over, we did the check angiogram. So here we can see a magical result because there were chunky calcium deposits on the vessel wall, which was causing significant stenosis. With a plain balloon, we cannot achieve such a good result. Whereas here we can see there is a lot of remodeling of the calcific plaques, and we have achieved a very good flow in the, or a very good lumen size in the distal SFA and popliteal artery, and a very good flow. So then we repeated the similar procedure in the common femoral artery with a 4.5 balloon. Here we can see the pre-IVL image that there was a chunky mass of calcium, rocky calcium, which was seen in the common femoral artery, causing an eccentric stenosis. So what happens when we use a plain balloon is the normal wall of the balloon actually significantly overdilates. The balloon actually significantly overdilates the normal wall of the CFA and results in contour abnormalities or dissections or rupture. Whereas we can see that in the post-IVL angios that the calcific plaque is well modified, is remodeled, and we have the normal contour of the opposite normal wall, and we have a very an acceptable residual stenosis of 20 to 30%, which is quite acceptable in this region. So this is the benefit of using a technique which actually modifies the calcium rather than treat the normal vessel. So once the lithotripsy procedure was over, we went on to have an adjunct technique to increase the long-term patency with the regulating ballonplasty of all the segments that we have treated with the lithotripsy from the popliteal to the CFA. Post-procedure, the patient's popliteal pulse was palpable and he symptomatically improved with no limitation of daily activities. We had a subsequent session for the left SFA, short, minimally calcified occlusion in the distal segment with just stenting and angioplasty with symptomatic improvement. Patient went home fine. He was started on dual antiplatelets prior to the procedure with ticagrelor 90 milligrams twice daily and aspirin 75 milligrams OD, which was to actually improve the patency rates. So to conclude, calcified peripheral vascular disease, which is significant, which is severe, is going to cause so many issues during revascularization with standard plain balloon angioplasty and stenting. Atherectomy is one of the options, but one important disadvantage is it doesn't address the medial calcium. We have this lithotripsy technique, which has actually revolutionized the treatment of calcific peripheral artery disease in recent times. And one advantage is it doesn't harm the soft tissues. There are very low rate of complications. Even in a distant PAT3 study, we have noted that the rate of complications is close to 1%, which is very good. And the success, the technical or the clinical success of this procedure is going to depend more on patient selection or the lesion selection, as well as sizing of the balloon with reference to the reference vessel diameter, and choosing a very good adjunct technique which is going to increase the long-term patency. So as we have all seen, the complication rates have been exceedingly low, and this is a boon actually in treating calcified peripheral vascular disease. We have seen quite a lot of aortic lesions being treated, and this is a femoral artery lesion which was treated successfully, and patient is doing very well. Thank you for this opportunity, for the organizers, and also Mathew sir for giving me this opportunity to present this case here. Thank you.
Thank you, Dr. Santhosh, and congratulations to you, Dr. Cherian sir and Dr. Mehta. And I think we can have a discussion on the last 4 cases. Dr. Gireesh sir presented a case of popliteal artery thrombosis, which were very nicely managed in an innovative way. And Dr. Manoj for presenting 2 complex cases of IVL in which he used hemodynamic devices to modify the subclavian artery plaque. And then Dr. Charudutta, in which he reconstructed the aortoiliac segment. And the last was by Dr. Santhosh, the right leg CLI, which was managed nicely. I think we invite discussions from the panelists and chairpersons.
Very interesting cases. If I can ask Dr. Charudutta, his choice of using a seat and trouser stent in this particular case that he showed, any particular reason of not using a double barrel and using a seat and trouser approach? Because it is a very large sheet that you put in. It's a little bulky stent when you put in the aorta. So any reason why you choose that?
We didn't, it was a long segment, so didn't want to use 2 long kissing segments going up that length, which was almost 4 centimeters. So wanted to avoid that much of kissing segments in the aorta, and could give a single barrel definition to the aorta, and maybe just give it a small kissing segments, which is likely to give a little longer outcome than putting 2 kissing stents right up till there, almost 4 centimeters up.
Your iliac stents are also balloon expandable stents, I thought. Yeah.
No, they were longer requirements, so we had a self-expandable stent.
Okay.
See, now your aortic, what are the aortic diameter actually? I didn't get it. I don't remember rather. The stent that used in the aorta, what was the diameter?
No, this was expandable up to 2.3. You could expand.
What was the final diameter?
Final diameter achieves were around 16 or 17 mm.
Yeah. No, what I meant is, so why couldn't you take a self-expanding stent with a much smaller profile?
Self-expanding stent would, the difficulty in deploying there exactly at the bifurcation was there. When we are deploying a self-expandable stent, would probably jump a little forward. Was our concern.
I don't think the current modern stents jump anymore. I don't think that happens really. No, I just said it because you have a 12 French device. There is no additional great advantage. And you could take a barred stent, which would have given you 16 mm. And I mean, honestly, I don't think jumping would have been an issue. Even if you were 2 millimeters above the bifurcation, anyway, your two limbs would have gone inside. I mean, I just wondered because this is a very expensive stent. And barred stent is about, 1/4 the cost, And I don't know. I mean, I personally would have just used
Illuminex. You would have probably used an Illuminex that you a lot of sizes, 40, 60, 80, 100, whatever size you want, you get it.
Long lengths are there. So you could have covered the whole aorta. You got a 6 French profile.
Yeah.
And a very cheap stent. I don't know why these guys charge so much for this balloon expander, which I have no idea. Probably because there's no other company making it.
Monopoly.
Charu,
absolutely.
Charu, any comment about say barrel separate two stent vis-a-vis one stent in the aorta, pajama stent, any long-term patency and ease of repeat intervention in two subset?
I think previously we've been doing kissing stents. A few cases have come back with restenosis and all. So probably we thought this is the first case we did actually do away from a long kissing segment stents and thought of doing a single.
Charu, did you consider 2 covered stents?
Yes, we
but
did.
You know that the patency are very good today. If you use atriums, 2 of them. I mean, I'm just talking possibilities. I mean, honestly speaking, I also don't like the concept of taking 2 metal stents side. There's a lot of turbulence in that segment. But having said that, it's not as bad as one presumes. But I don't like to use a stent. How much did you pay for that stent? 1.6 lakhs or something?
I think 1.2.
No, covered stent is more expensive. The uncovered are about 1.2, 1.3.
So actually, CRAM had come in a big way for this kind of aorta. Basically, that is covered endovascular recanalization of aortic bifurcation. But somehow the major challenge with that was the finances, because you're using covered stents. Dr. Mathew also mentioned using Advanta. Unfortunately, we don't get them nowadays. But otherwise, that was one option which did come in a big way. But then I think it is over a period of time, having good, sturdy stents like self-extend long segments and all probably do very well. I think equally well for that matter.
I just wanted to ask one question. With this IVL, even for the aorta, if you get a good result, looks-wise, and your gradient goes, is it compulsory to stent then?
No, Gireesh, I agree with you. I honestly think it's not very necessary. You know why? Because coral reef aorta is something that the long-term results are unpredictable,
Right.
And if it's kind of a dystrophic calcification. So you put a stent and it comes back again with this calcification all over. It's going to be technically more challenging, and that is something I agree with you. That if you get a good result, probably should just come off, and and that's my strong. I feel the same way, because honestly, this is not exactly like a standard atherosclerotic aorta.
Correct.
I think the principle remains the same, to have a gradient less than say 20 millimeter, whether it's a porcelain or coral reef aorta or a normal aorta. And with the IVL balloon, which is of say 7 or 8 millimeter size in aorta, which is 14 or more, one has to go ahead and put the stent to have a gradient less than 20. That's what I feel like.
No,
in case it is not, then you can have a repeat evaluation at the follow-up by the ankle brachial index or other way to have an idea about. And of course, they do need the repeat intervention in case the optimal result is not there.
No, I think we use a double balloon always.
Yeah.
Gireesh, and what Gireesh said, his question is very clear. He says, if I get a good result, if my gradient across is like 15, I mean, do I really need to stent again? I mean, he's not talking about a situation where he's saying, do we do an elective stenting versus a bailout stenting? I mean, that's exactly what Gireesh is telling.
Correct.
And I am totally agreeable of a bailout stenting, but I think whether we should go ahead with the elective stenting.
I think as long as your gradient is below 20 millimeters, I think you can avoid
some of these.
One more question I wanted to ask was that where there was a juxtarenal calcium and also bilateral renal artery stenosis. Could we have just done IVL and leg beam, even for the renals?
See, Gireesh, that's two way of looking at it. One is just do the IVL, have a look how things settle down.
Correct.
Yeah, and do it as a second stage procedure. Or like I said, I would of course leave the wires inside definitely, because I do not want to lose the renal artery in the process. And think at the end of the procedure whether I need to stent it, I think that will...
regarding using IVL in the renal artery, because you see the length that you have is only it's a 4 centimeters long. That's pretty long one. The rest of it.
No, but you have coronary balloons also, no?
No, coronary balloon one can probably use. That is one option there. Sorry.
Coronary they go up to 4 mm, so you can use it.
Yeah.
No, for the case, what Dr. Milan has shown about, he had a good result with the balloon dilatation stenting across the left renal. So I think it was not so calcified compared to what the aorta was having. And putting a stent across the right renal, I think there must be some plaque shift across during the balloon dilatation of the aorta, and therefore he had put a stent across the right renal as well. There was some dissection as well after doing the balloon dilatation across the aorta, though the follow-up ankle brachial index was okay, but then I think there is a need to have an imaging across the coral reef aorta to look for what the dissection, how much it has progressed or regressed, and to decide of the further intervention.
But he has not put a stent in the aorta, no?
There was a dissection. If you see, there was a big dissection on the right side after the balloon dilatation.
Right. Of the aorta?
Yes.
So, but he has not put a stent in the aorta.
Yes, absolutely. He has not put the stent. But then there was some problem with the right renal that he couldn't clarify about. Initially, the right renal
said there was a critical
fine.
stenosis and he stented it electively. I mean, at the end of the process.
So he had, there was a stenosis on the left renal. The right renal was normal.
I asked him that question. I had the same doubt. He said it was bilateral.
There was renal artery stenosis bilateral.
Bilateral.
That's what he... Yeah.
It was clearly visible in the axial pictures.
Yeah, correct.
Dr. Rajesh, you had also presented one case of coral reef aorta in one of your publications, I think.
Yes, I had one coral reef. It was before the IVL was there with us. So I had, it's a juxtarenal coral reef aorta, and after balloon dilatation, there was a dissection for which I did put a self-expanding stent. Across a balloon expandable stent of that particular size was not available at that moment of time. And then, of course, it was not a case to go ahead for say graft stent across because of the mesenteric artery and the renal artery, and I could achieve a good result. The blood pressure and congestive heart failure improved, and we could publish it in the BMJ case report journal.
Nice, sir. Overall, everybody presented a variety of cases, right from the supraortic segment to the thoracic aorta, abdominal aorta, and aortoiliac segment. Gireesh, sir, I have one question. Can we use a thrombosuction catheter to suck that plaque rather than pushing it down?
Doesn't come out.
Doesn't come out.
Doesn't come out. Because it doesn't come out.
See, for taking out by thrombosuction, the mandatory requirement is your suction catheter should wedge the vessel. That never happens in that segment.
We do have 7F aspiration catheter for the coronary, so that can also be tried over here.
No, we use the cerebral ones, which are much larger actually. The lumen is much more larger. We got up to 7.0 actually.
You can use Turbohawk in this one. Turbohawk is the only thing.
No, but
again, you're worried about it going down.
No, but Gireesh, you did a good job, man.
Yeah, absolutely.
You can call it by a name, called the tractor or bulldozer technique or something. Before somebody else puts it in.
Gireesh uses his head. Gireesh uses his head. Very effective.
Or you can call it the butt head technique or something.
Now, this is not the forum to crack another joke on that one, but I'll explain.
Overall, it was very enriching in the knowledge, and all of us have gained something today. And thank you for organizing this seminar and a lot of discussion.
Actually, if they could bring down the price of this balloon and give longer balloons, I think we use it a lot more, because honestly, the restriction is that can I put 2 of these balloons across the iliac? It's a price that's a big constraint, actually.
That's what we've been conveying to the company.
Yeah, you ask 2 lakhs per balloon. You need people from UAE or somebody to put such bills. So in the case we did, we had these 2 balloons, one for the popliteal and one for the CFA.
The problem is we cannot read on the system.
That guy from Dubai was happy. He spent that bill. They should have got disappointed.
Thank you.
Okay, guys. Thank you very much.
Thank you.
Thanks very much.
Thank you. Thank you.